Right. So, good morning, and let's try to complete off one of the major chapters today, uh, cardiovascular system. It is not really so difficult. It is comparatively, with the respiratory system, it is quite easy one, unless you are familiar about the physiological processes and the circulation of the heart, as well as you know learning about different anatomy, and particularly we use radiology in the diagnosis very less these days. Radiology has been such kind of an imaging modality. Radiology, in the sense I was talking about, particularly chest X-ray, mostly. Um is not a routine examination done for a heart disease. Generally, any kind of a person that complains of chest pain, particularly speaking, if he complains of unstable angina, the gold standard test is always an electrocardiogram, ECG. And then if the patient has been complaining of any kind of hypertension or any other uh, cardiovascular related symptoms, we generally go for much more specific tests that are higher and superior than a chest radiograph itself. For example, to say I'm talking about the color Doppler echocardiographies, uh, and most of the times we are going to go for the markers, right? But however, in routine setups for a general physician, we generally do not use uh, a, uh radiological investigation, especially a chest radiograph, for the complete diagnosis of the uh, cardiovascular system. But however, uh, there are some better, easiest ways for a radiologist to know about the cardiovascular status. So today we will be learning about some of the few diseases which a radiologist actually tries to diagnose in situation of a cardiovascular complaint, right? Uh, this subject, this chapter is technically a little confusing, but not difficult, okay? Because you have already known about so many of the basic lesions in that comes down in a chest radiograph. So we will be using all such kind of information here and try to correlate it with the pathophysiology and the normal physiology of the heart, so that we can actually diagnose a adult heart disease. So how do we recognize an adult heart disease? The first thing, anywhere, it is very important when you are trying to look at the adult heart disease is, you know, in all the previous x-rays, what we have been learning in the previous chapters, what we have always been doing is that we are just looking at the lung fields. We are looking at the soft tissues. We are looking at the bony orientation. But until today, except for in case of atelectasis, pleural effusion, and pneumothorax, uh, we talked only specifically about the mediastinal structure, right? But we never usually talked about anything that is related down to the heart itself, heart as a single entity, heart as a single organ itself. So we have never talked about the heart in an individual way. So this chapter is completely dedicated to heart. Now, any kind of a simple problem, generally we have to make sure if the heart size is normal or abnormal. We know about the contours of the heart. We know about the borders of the heart already. So we have known that a superior vena cava shadow, inferior vena cava shadow. right atrial shadow, right ventricular shadow, left ventricular shadow, left atrial shadow, and then ascending aorta and aortic knuckle shadows. But we never talked the heart as a whole. Uh, so, in generally understanding of a cardiovascular status, the first thing a radiologist should be always doing is to assessment of heart size, which means to say we are measuring the heart size, because a simple physiological thing is that we know that any time the heart is a mobile structure, it is continuously having contractions and relaxations, which is called as the systole and diastole. And then it is circulating blood all over the body and receiving the blood from the body. So the heart size has got technically some kind of a relation with its pressure gradients. It has got a relation with its output, which is called as the cardiac output, and it has also got how much of the blood is released in every systole or diastole, right? Either it receives or how much it is receiving or how much it is circulating. So ejection fractions and everything. So we are going to look at the heart size because it is going to give us some kinds a direct evidence or some kind and sometimes an indirect evidence to its real status. But you always remember radiology is not plain radiography in the sense an x-ray, a chest x-ray is not a gold standard test for observation of cardiopulmonary status. Okay, if you are trying to look for only pulmonary status, yes, the always the modality that is gold standard today in the present days is a CT scan. All right, CT scan is much more superior than a chest radiograph. But for when compared for the chest radiograph, when assessing for the lungs, and particularly if you are looking at the heart, generally, see, even if you are suspecting some kind of a heart disease, the chest X-ray will not, sometimes may not give you the complete information unless you are familiar about some things. Okay, a physician will not be able to learn about these things, but a radiologist will generally know the technique of how to correlate its physiology and pathophysiology to the appearances that are present on the any radiograph that is presented to him. So heart size is always assessed, measured on a frontal radiograph. So let's try to see what exactly, how do we do it? So there is three conditions which actually make the heart size appear bigger. So a simple uh, logic that what we remember is that anything that is happening down in the pericardial space, okay, there is a pericardial layer surrounding the heart, and inside it has got the same layers like the visceral layer and the parietal layer as well. Viscera in the sense it is close to the heart, and the parietal is the one that is outside, that is present anterior and posteriorly. It is surrounding the heart, right? So there is a space in between them which is called as the pericardial space, and there is pericardial fluid in it. So if there is an increase in the pericardial fluid, the levels of the pericardial fluid, we call such kind of condition called as the pericardial effusion, right? So this is the first and foremost disease that a radiologist will be thinking about if it increases the cardiac size, because this pericardial effusion, more increase in the pericardial fluid, mimics the appearance of a cardiomegaly. Cardiomegaly is nothing but increase in the size of the heart, overall size of the heart. Okay, remember, do not confuse with the chamber enlargements. Okay, chamber enlargements are entirely different. Chamber enlargements, in the sense, when I'm particularly talking chamber enlargement, I will be talking about the location. For example, to say I will be talking about right atrial hypertrophy, I will be adding the side, and I will be adding the CLOT that is involved. Okay, so right atrial hypertrophies, right ventricular hypertrophies, left atrial hypertrophies, left ventricular hypertrophies. But this one, I'm particularly talking about cardiomegaly. When I'm saying cardiomegaly, I was unable to interpret if the heart size increased only in a single chamber or if it is increased the heart as a whole. Okay, so do not confuse the chamber enlargements with cardiomegaly. Cardiomegaly is always meant to say there is a gross heart enlargement, or you can say there is a gross cardiac enlargement. Okay, so pericardial is one such kind of a condition that actually mimics the appearance of a cardiomegaly. Then there are a few other things that are called as the extracardiac factors. We will look into them in slowly. Extracardiac factors that actually produce an apparent cardiac enlargement. Apparent cardiac enlargement is that the actual size of the heart is not really big. It did not enlarge in its size, but actually the appearance of due to the surrounding structures made it to be bigger. For example, to say when we are talking about an AP view, when we are talking about a supine position, when we are talking about a pure inspiration, pure expiratory film. So those such kind of factors, okay, these are the quality factors, but we'll get into pathological conditions slowly. So those are the ones that actually make the cardiac size appear a little bigger. So we need to know which one is normal, which one is actually abnormal. And the last one is the true cardiac enlargement. True cardiac enlargement is the one that I am talking about, specifically about the chamber enlargements or a gross cardiomegaly. A gross cardiomegaly in the sense is that, okay, I'm talking about cardiomyopathic diseases. Cardiomyopathic diseases where the real cardiac muscle, okay, is getting enlarged by its own. So that's what is the difference between a apparent cardiomegaly and a gross cardiomegaly. So pericardial effusion and extracardiac factors are the conditions that causes apparent cardiomegaly, and true cardiomegaly is happening down in chamber enlargements and myopathic diseases. So we'll be learning about those diseases one by one. It is very easy, right? Now you have to remember one thing. First, we'll try to learn about the pericardial effusion, and then we will see how we are actually measuring down the heart size. Right. Pericardial effusion, the first thing you have to remember, there is something around like 15 to 50 ml of pericardial fluid in the pericardial space. And it has got the same thing. It has got two layers, the parietal layer and the visceral layer. So there is an increase in the pericardial fluid in the pericardial space because it has accumulated between the visceral layers and the parietal layers. Very, very simple. It is same like the pleural effusion. Okay, pleural effusion is happening in the costophrenic recess and it is happening in the pleural space. The same way, the fluid accumulation is happening down within the pericardial space. So that is what a pericardial effusion is. So generally, more or less speaking, how a pericardial effusion appears down, how a pleural effusion appears down on a chest radiograph, more or less the same. Pericardial effusion also appears the same way around the mediastinal areas. Simple, right? Okay. Since there is a blunting of a costophrenic recess in the pericardial effusion, we will be talking about exclusively pericardial space. Okay. But it is not blunting of the cardiophrenic angle. Okay. So don't misunderstand it that way. Right. So abnormal accumulation of the fluid begins in the dependent portions of the pericardial space. The same way, okay, same way like the pleural effusion gets settled down in the dependent area, that's the same way how a pericardial fluid also gets settled down in the pericardial space, which is in supine position, the posterior to the left ventricle, okay? It is the posterior to the left ventricle. Remember this region, okay, posterior to the left ventricle, because it has got enough space, okay, increased area for the expansion of the heart, because the left ventricle posterior side requires more expansion, okay, right? The presence of the left ventricle is present more onto the posterior side rather than on the anterior side. I think you should have known about this anatomy beforehand itself. But unless it is related to the pathology, I will not be discussing about such kind of anatomical relations yet. Okay. Now you have to understand one thing, that the posterior side of the left ventricle has got some little extra space so that it can provide enough expansion or enough relaxation of the heart. So that is the more dependent area where a pericardial effusion will be, accumulating. Now, as the pericardial size, effusion size increases, what actually happens, it also tends to accumulate along the right heart border. So, which means to say a minute pericardial effusion will be evaluated in the posterior side of the left ventricle, where as a slowly increasing pericardial effusion will also be analyzed along the right heart border, okay, until it fills the complete pericardial space and it starts encircling the heart. So a minute pericardial effusion is in the posterior to the left ventricle. A massive pericardial effusion will start from along the right heart border of the heart and finally encircling the heart. Remember, this is the difference. So a radiologist should be able to analyze the fluid densities on CT and on X-ray in both the posterior side of the left ventricle and also along the right heart borders. So is there any obscurity? Is there any increase in the diameter of the right heart border? Will eventually tell me if there is any pericardial effusion or not. But remember, conventional radiographs cannot assess the posterior side of the heart unless we are going to take a lateral film. And at the same way, the fluid densities and the changes in the densities and differentiating it from the density of the real cardiac shadow, means to say myocardial muscular shadow, related to the fluid density cannot be differentiated on a conventional radiograph. AP view or a PA view, a traditional radiograph cannot analyze this one. So the gold standard test for assessment of minute, moderate, and massive pericardial effusion is always a CT scan. Okay, remember, CT scan is the completely a gold standard test for demonstration of a pericardial effusion. See, Reshma, you are talking about 2D echo. Yes, you see here, 2D echo is also one of the modalities that is considered known as a superior modality that, you know, necessary for evaluation of pericardial effusions. That is true. But generally, 2D echo has been more confined down to therapeutic procedures these days. For example, to say if I'm going to make a procedure called as paracentesis, it's a bedside diagnosis, okay? 2D echo is a bedside diagnosis. But if I'm going to look about the chambers condition, if I'm going to look about more blood vessels situations, if I'm knowing about the complete extension of all into the mediastinal spaces, you see here there will be a lot of exploration that should have to be done on a 2D echo. It is difficult because not everybody can handle an ultrasound machine. 2D echo interpretations, echocardiography interpretations, ultrasonography interpretations is generally preferred as a bedside diagnosis. Okay, it's a bedside investigation, right? And generally there will be a lot of misinterpretation unless we don't know how to handle an ultrasound machine, and experience counts, the technique counts. But a CT scan is more like a digital camera. Anybody can handle it. logically speaking. Okay, even if an amateur undergraduates like us, what actually they do is that, even if I show you some kind of a picture, even without me telling you, you can actually get an instinctive feeling that something is wrong with that radiograph. But on echocardiography, no, you will not be able to figure out, even if I'm giving you a very, very much detailed information, and I'm giving you very detailed information about the echogenicities, how I look, how does the pericardial effusion looks, how a normal cardiac muscle looks. You will not be able to, elaborate that one. But since like the digital photography that everybody is able to appreciate, even by looking at a simple CT scan, a undergraduate with no information also will be able to get an instinctive feeling that something is wrong around the pericardial area, right? Yes, 2D echo is also one of the good modalities to be done, but gold standard, we will be considering it down as pericardial effusion. All right. Okay. Now, how does actually we look like? You see here, this is not a normal radiograph. Okay, this is an abnormal radiograph. You see here the heart shadow, which is a homogeneous hyperdensity. See here, this is a homogeneous gray shadow. And when you are looking close enough, there is a shadow that is a little less dense, okay, which means to say a little lower density, which we actually call as attenuation, okay, decrease in the density, decrease in the Hounsfield units, okay, decrease in the Hounsfield units of a structure is called as attenuation or attenuation, okay, attenuation or attenuation. So which means to say there is a substantial loss of density, measuring density Hounsfield units, okay. So there is, but we call it as hypodense and hyperdense also on the CT scan, but we generally call it as an attenuated density. When I'm calling it as an attenuated density, I'm comparing it to the surrounding structure. So I measure the Hounsfield unit here, and I measure the Hounsfield unit here, and I will understand, okay, this is much more attenuated. Now, if you can remember your general principles class, tell me what is the Hounsfield unit for fluid? What is the range of Hounsfield unit for fluid? Do you remember it? What is the Hounsfield unit for air? What is the Hounsfield unit for bones, metals, everything? See, 0 for water, and 0 to 10. Okay, we will call it for fluid, right? Yes, 0 for water. So if I am measuring, and I will measure the attenuation unit exactly at this place, right? The first thing I'm going to do is that I'm going to measure the attenuation here, Hounsfield density, here at this place. And then immediately what I'm going to do is that I'm measuring it here. So I will compare the both densities and see here if this is a cardiac muscle or if this is a fluid. So once I get the ranges between 0 to 10, I conclude myself that I'm looking exactly at a fluid. So which means to say I'm looking at the pericardial area. So that should be a pericardial fluid. Now, the second thing what I'm going to do is that this is the dependent area. Okay, this is the left side of the heart, and this is the left ventricle I am looking at. And you see here, compared to the diameter along here, this diameter is a little bit higher, you see, right? Compared to the length here measured from this part to this part, this area has got higher diameter. So this became the most dependent part. So first what I'm going to do is that, okay, I'm going to measure the diameter, the length from this shadow to this shadow and see if it is extending beyond 1 centimeter. Okay. If it is beyond 1 centimeter, I will come to understand that yes, there is an increase in the cardiac diameter on the posterior side. And this diameter is increased indeed because of this fluid attenuation on the posterior side, which means to say I am talking about a pericardial effusion. Is this clear now? See, the first thing I do is that to look for the fluid. Okay, and I wanted to make sure I'm just looking at the fluid shadow. If I'm not, if I, once I make sure that, what I'm going to do is that I'm going to measure the diameter at random levels. Then I'm going to see how much there is increase. If there is an increase in this diameter, particularly greater than 1.5 centimeters, I am going to learn that yes, I'm looking at a pericardial space which has increased the diameter due to a fluid attenuated density. So which tells me I'm looking at a patient of pericardial effusion. Is this clear now? Once again, Aman, is it clear? For everybody, is it clear? Okay. First, I measure the densities. Then first I make confirm that I'm looking at a fluid density. Once I get myself confirmed if I'm looking at a fluid density, I'm going to measure the diameter from this density changing areas. Then if it is present greater than 1.5 centimeters, I will come to understand, yes, it is indeed a pericardial effusion because I'm looking at a fluid density. And this is the most dependent part of the pericardial space, right? So unless there is a massive pericardial effusion, it does not encircle the heart. So the first area for a pericardial effusion is always the posterior side of the left ventricle. Remember, the same way how in the pleural effusions also, unless and until there is more than 250 ml of the fluid that is not visible on a chest radiograph, that is the same logic also we are using here. There is no difference, okay? It is just the change of spaces, okay? One is the pleural space, other is the pericardial space, but still the dependency of the portion still hangs out the same way, right? Now you look here, this one is much more clearer. You look here, when compared to this density, okay, this one is an attenuated density, yes or no? When compared to this one as a homogeneous density, this one is much more attenuated homogeneous density, and it is encircling the heart, yes or no? See, all over the diameter of the heart has been increased, right? When compared to this density is a little bit lower, which means to say this became an attenuated density, which means to say obviously I am looking at a fluid density. So the fluid density, what is the fluid that is present around this place? It is the pericardial fluid. But let me ask you a question. If this could have been the blood, if this could have been the blood rather than being a fluid, how will the density be? How will the density be? If this place has got filled up with blood, okay, so how will this look like? More density, and it will almost look the same like heart shadow, almost, right? Almost same like the heart shadow, because the blood has got a little bit of mixture with the pericardial fluid, 15 to 15 ml, so it became diluted, and yes, it will almost look like the same density of the heart, but much more higher density than the fluid density that is present here. So that's the reason I am using a technique called as measurement of Hounsfield units. Did you understand now? Why I'm measuring for the attenuation? I'm measuring for the attenuation to just to know the Hounsfield units, because the Hounsfield unit value itself tells me what kind of a fluid I'm looking at, right? Did you understand? So it is much more easier than a chest radiograph. Is this clear, guys, now? Yes or no? Right? So you see here, this one is surrounding the heart, and you see here, obviously the diameter, okay, since we do not have the scale here, so that's the reason we are not able to measure it, but it will be something around like 3 centimeters of increase in diameter here, okay, all over the cardiac space, okay, all over the pericardial space, okay, the diameter of the heart is increased. But do not confuse yourself that this overall thing is the diameter of the heart. No, This is not the diameter of the heart. The real diameter of the heart is the one, this hyperdensity that I'm looking at. So is there any real cardiac enlargement? Is there any real cardiac chamber enlargement? No, but there is a restriction to the movement of the heart to expand to the fullest. Yes or no? So such kind of condition is actually called as constrictive pericarditis. Okay, constrictive pericardial effusion is one of the clinical condition which will actually cause such kind of an appearance. Okay, so how did I make myself a diagnosis like this? It is called as constrictive pericardial effusion. So tell me, what are the conditions that will cause a pericardial effusions? What can you think of? What are the diseases that causes pericardial effusion? So the diseases that actually cause pericardial effusion are same like the one what we learned for the pleural effusions as well. Most of the congestive heart failures, TB, viral, okay, viral infections, TB, and then metastatic malignancy, especially from the lung and the breast, uremic pericarditis, collagen vascular diseases, systemic lupus erythematosus, okay, discoid lupus erythematosus, trauma, okay, blood, and post-pericardiotomy syndrome. All of them are the diseases that actually cause their increase in the pericardial effusion. So the disease is not about finding, see, you see here, right now you should be understanding, since the same way a finding of a pleural effusion is not a disease, that's the same way finding of a pericardial effusion, yes, it is an observation made on a radiograph, but it is not the disease. Pericardial effusion in medicine you will be talking about as a separate disease. But here you have to understand that the main reason for this disease is for this condition of increase in the pericardial fluid is different when compare is entirely different. You have to work and explore more down into the etiological factors that actually caused an increased pericardial fluid. Okay, so that's what exactly we are going to do. Pericardial effusion is a condition, is an observation made on a radiograph or an echocardiography, and you have to explore more down to treat the real etiological condition that's actually causing this increase of the fluid, right? So these are the conditions: congestive heart failures, especially, which is the most common one, and then metastatic disease, the being the second most common one, and infections also being as potential as possible. And then trauma in most of the conditions are the most common conditions that causes an increase in the pericardial fluids. Increase in the pericardial fluid is called as a pericardial effusion, right? So now this one is actually causing apparent cardiac enlargement. The real size of the heart actually is not big, but it is letting the appearance of the mediastinal space to become bigger. So the heart itself, it is in normal size, okay, but on conventional radiography, if I'm going to measure the cardiothoracic ratio, since I cannot differentiate between the real cardiac muscle shadow and the fluid shadow on a chest radiograph, I will be misdiagnosing this person as a gross cardiomegaly or a cardiomyopathic disease. But so that's the reason this is called as an apparent cardiac enlargement. So we cannot do it. And you have to remember one thing, okay? You have to remember one thing, that a pericardial effusion will look like a water bottle configuration. Remember, this is a very important point, okay? Water bottle configuration. Okay, a pericardial effusion will have the heart appear like a water bottle in the sense, okay, leather bag filled up with water. Okay, before we do not have the plastic bottles. Okay, we used to have only the leather bags to carry water. Now let us say if you take if you fill some water in a balloon and put it on the floor, so how exactly the shadow of that water balloon looks like, that's the same way how a water bottle also looks like. And that's the reason we call this one as water bottle configuration. So a water bottle configuration of a heart on a conventional radiograph suggests it is a constrictive pleural effusions. Okay, constrictive pericarditis and pleural effusions. Okay, pleural effusion has got a water bottle configuration. Do not forget this. All right. Now, how are we going to look for there is a cardiac enlargement or not? Now, remember one thing. We are talking about extracardiac causes that actually causes increase in the heart size, but the normal cardiac muscle may be normal itself. Okay, so it is causing an apparent cardiac enlargement. So how are we going to measure it? One, first we will be knowing about what are the conditions. Like I said before, yes, there is an AP, portable supine chest film is the one that causes the magnification of the heart shadow, which actually lets it appear to be that there is a cardiac enlargement. But this is not true for a PA view. So PA view is a standard view. On an AP view is a portable supine position due to the pushing up of the diaphragm, okay, pushing up of the diaphragm, and also being settled in the heart in the retrocardiac spaces. What happens is that there will be apparent magnification of the heart shadow. So AP view has appears to be like a cardiac enlargement, but it isn't. Then suboptimal inspiration, okay, in expiration the diaphragm moves upwards and compresses the heart, making the heart appear larger than it would be in full inspiration. And if there are 8 to 9 posterior ribs visible on a frontal radiograph, the inspiration is generally adequate. Yes, 8 to 10 we call it as generally, okay. 8 to 10 and 6 to 7 anterior ribs that are visible on an anterior in a PA view will actually tell that there is an adequate inspiration. But if I cannot find out the posterior rib shadows, then I came to understand that this patient is not having full inspiration, and indeed maybe the patient has been taken down an expiratory film, or maybe the film was taken down to uh, when the patient is expiring. So that one will actually cause like an cardio enlargement. Okay. And you have to remember there is a difference between an expiratory film and film taken on expiration. Okay. See, film taken on expiration is that, okay, the patient was always instructed down to inspiration and expiration. Okay, right, the patient will always be doing the inspiration and expiration, but the patient was particularly instructed down to hold his breath in inspiration, but the patient could not, and the technologist also could not synchronize with his inspiration and accidentally took the picture down in expiration. So that means to say the picture was taken on expiration. But there is another view that is called as the technician instinctively, the technician intentionally takes the film down in expiration itself. So the expiratory films are prescribed in case of a pneumothorax. Don't ever forget this. Expiratory films expiratory films are prescribed if there is a suspicion to pneumothorax. Okay, if the physician is suspecting if the patient might have a pneumothorax, yes, he actually wants an expiratory film. So there is a difference between film taken in full expiration and film taken on expiration and expiratory film. Okay, expiratory film is that the doctor wanted the patient to have expiration and take a film, but film taken on expiration is generally the technician accidentally took the picture rather than taking it in inspiration, took it on expiration. Okay, is this clear? Right. And then the other conditions like morbid obesity, morbid obesity, something around like greater than 30, 28 to 31 or more higher. Okay, obesity, BMI ranges. Okay, pregnancy, and ascites. Ascites means to say accumulation of fluid down in the retroperitoneal areas. Okay, these all conditions will actually also cause the prevention of adequate inspiration. Okay, these all conditions will actually stop the heart from expanding fully because the diaphragm will be pushed up because of inadequate inspiration. Okay, so obesity, pregnancy also, you are actually talking about the second trimester pregnancies, not the first trimester pregnancy. You will learn more about them in gynecology, because in the first trimester pregnancy, the uterus size with a active fetus, okay, live fetus, will not be above the level of umbilicus. Only if the uterus size gets beyond this level of umbilicus, that is where you will be actually having an influence on your respiration. Okay, pregnancy, but actually as the baby size increases, as the fetus size increases, there will be more fetal demand for oxygenation, there will be more fetal circulation, increase in the blood pressure of the mother as well, to compensate the blood circulation and also compensate for the oxygenation of the fetal circulation. So all these conditions, there will be apparent increase in the cardiac sizes, one, which is actually called as pregnancy-induced hypertension or gestational cardiomyopathy. We will talk about that condition slowly, okay? But here, what happens is that only the uterus size. So it doesn't matter what is there inside the uterus. Okay, if it is even, let us say, even if the baby size is small, but there is a lot of amniotic fluid. What do we call this condition as? Polyhydramnios, right? Okay, I think, did you hear this word before? Did you hear this word, polyhydramnios? Okay, polyhydramnios is a condition where there will be increase in the amniotic fluid. Okay, the baby is around inside the amniotic membrane, right? Okay, the baby is inside and there is a lot of fluid in it, right? There is a fluid inside, right, which is actually called as amniotic fluid, right? Yes or no? Which actually supplies the nutrients to the fetus. Didn't you learn this in embryology? Yes or no, guys? Okay, so the increase in the amniotic fluid is actually called as polyhydramnios. Okay, polyhydroamnios. Amnios, amniotic sac, hydro, water, fluid, poly, more. So increase in the volume of the amniotic fluid, polyhydramnios. Did you understand how the definition came out? Okay. So such kind of condition will also increase the size of the uterus, but the real size of the fetus is small. So, but still, since it all of the one that are present down in the uterus is actually pushing the intestines, and intestines thereby pushing the diaphragm further, and diaphragm thereby compressing the heart, will actually cause the heart to not expand, and it will look like a cardiac enlargement. Is this clear now? Okay. Not every pregnancy patient will have such kind of appearance, but only a second trimester pregnancy will actually call this one. Okay, second trimester pregnancy, where the size of the uterus is beyond the umbilicus. But you should be asking me a question here. Sir, if you say that there is the CT scan is the gold standard test for observation of a pericardial effusion, and you are talking that pregnancy is a cause of apparent cardiac enlargement, so should I be thinking about pericardial effusions in case of pregnancy, or should I have to prescribe a radiograph in case of a pregnant woman? The answer to these questions is both logical and as simple as they are. We don't prescribe a chest radiograph or a CT scan when we know that the woman is pregnant. Now, why I'm telling you this? There is a condition called as pregnancy-induced hypertension. The hypertension that happens in a pregnant woman. A chamber enlargement of the heart that happens in a pregnant woman, which is actually called as gestational cardiomyopathy. Okay, cardiomyopathy, gestation means to say pregnancy, gestational cardiomyopathy. There is a condition which will actually cause and increase the cardiac output, which will actually put an extra pressure on the heart. Okay, it is called as a gestational cardiac myopathy, which is the reason for the pregnancy induced hypertension. So how will I diagnose this condition? You have to make sure that you learn about the clinical scenarios, clinical presentation, symptoms, and clinical diagnosis of this condition, but rather than utilizing radiology for that. Did you understand why we are particularly talking about only this condition? Yes. Even if I'm suspecting that there is a patient, if see, let me give you like a case sheet. Okay, 30-year-old female who has a history of hypertension, has been suffering from hyperthyroidism, and also has gotten diabetes and has a history of hypertension. Now pregnant, comes down to your checkup. Now, you the first thing you should be thinking about that there is an increased risk of this person developing a gestational cardiomyopathy. So generally, you do not want to look at the size of the heart by looking it on a chest radiograph, and also you are not looking at a conventional CT. You are not looking at both of them and telling me that yeah, you have got cardiomyopathy. No, don't do that. So in such kind of situations, yes, we are going to use echocardiographies. Did you get it? But even gestational cardiomyopathy, also any kind of gross chamber enlargements, what is the gold standard? It is the CT itself. But only in special conditions we do not use it because of ethical situations, because we do not want to cause unwanted mutations in the fetus. Okay, but there are some exclusive conditions. Yes, for some people we will be doing the radiograph itself. I will show you. I have an example, that one, in which pregnant ladies we actually do a radiographs. Okay, now what exactly is this? How does this actually increase in the size? Remember the diameter of the heart. Okay, see here, the diameter of the heart compared to the diameter of the thoracic cage. Okay, the diameter of the heart compared to the complete thoracic diameter should be less than 50%. If it is less than 50%, it means to say, yes, there is no cardiomegaly. Remember, only on PA view. Okay, this definition applies only to a PA view. Did you get it? Okay, the diameter of the heart measured or compared to the total thoracic diameter is called as a cardiothoracic ratio. Remember, it's called as the cardiothoracic ratio. The diameter of the heart compared to the complete inner diameter of the thoracic cage is called as a cardiothoracic ratio. Conditions: one, it should be at full inspiration, and two, it should be a PA view itself. If you are missing both of these two conditions, it means to say there is a problem with the technique and your cardiothoracic ratio is not being less than 50%. Did you get it? But if you have followed it at PA view, if you have also made sure that the film has been taken down under full inspiration, but still the cardiothoracic ratio, the diameter of the heart is greater than 50% when compared to the internal thoracic diameter, yes, you can say that patient has the cardiac enlargement. Is this point clear now, guys? So do not confuse. This is a very, very famous question. and asking down as an MCQ and a fill in the blank. Okay, right? Very famous question. Most logical question is in cardiovascular system. See here, you have to remember for measuring down the cardiac enlargement, two conditions. One, it should be compulsorily taken down on a PA view. Two, it should be taken down at full inspiration. Okay, why? Because expiratory films and AP views will actually cause, even if there is no actual chamber enlargement, but it will make the radiograph look like as if there is a chamber enlargement. Yes or no? Right? Yes or no, Archana? Did you understand it? This full expiration and AP view will actually make the size of the heart look bigger due to magnification and compression of the diaphragm, right? Okay, just wait, Benedict. That's a good question. Okay, and then, but so we have to make two conditions for sure. Okay, two conditions for sure. One is that the film is taken down at full inspiration, and then it is also taken down at the PA view. And only on those two conditions, if the diameter of the heart is in greater than 50% compared to the diameter of the internal thoracic cage, is actually called as a cardiac enlargement. If it is greater than 50%, we call it as cardiac enlargement. If it is less than 50%, we call it as normal. Okay, do not forget this. Right, now Benedict, what is a condition that causes the atrophy of the heart? Is there any medical condition in the whole medical literature that causes atrophy of the heart? See, atrophy of the brain happens, atrophy of the muscles happens, okay, atrophy of some other organs, atrophy of the liver happens, right? Atrophy of the spleen happens, but does atrophy of the heart happen? Somebody answer me this question. Does the atrophy of the heart happen? Benedict asks a very interesting question. How about for an atrophy patient? Okay, what is the reason for atrophy? What is the most common reason for atrophy? Benedict, what is the reason for atrophy? What is involuntary? No, let Benedict answer. Benedict, what is the reason for atrophy? Okay, the reason for atrophy is that there is no, the main common reason for atrophy is the misuse of the organs, loss of organic function, severe inflammations, immobilities are the reasons for atrophies. Okay, not using the organ, bedridden patients, okay, or yes, infections sometimes in kinds of supposed to be brain. So that one is actually most common condition. So what is not using heart mean? If the heart cannot be used, is there any condition that is called as the heart cannot be used? Of course, the heart will be beating down when you are at 18 days of the heart, 18 days in the fetal time, okay, from 18th week, and until starting from there until you are dying, yes, you are be using your heart. If there is a misuse of the heart, yes, like he says, Aman says, the individual dies. So there is no atrophy of the heart. But your question is atrophy of the patient. If there is an atrophy of the patient, Yes, there is one kind of a condition that is actually called as tall individuals, or atrophied thoracic cachexia patients. Okay, cachexia. Would you call it as cachexia? Cachexia. Okay, those patients. Yes, yeah. See, brown atrophy of the heart is entirely different from this one. Okay, brown atrophy is not atrophy of the heart as a whole. Okay, yes, you are correct, Jabalina. That's true. Brown atrophy of the heart has got a different pathological and you know condition, but it does not actually cause that there is a a complete reduction of the cardiac size, which is completely apparent. No, it is not like that. Yes, atrophy of the heart is there, but the whole atrophy of the heart, misuse of the heart by definition wise, if we are saying, yes, it doesn't happen. Okay, tall individual and cachexia patients generally, yes, they present up with such kind of a condition where the heart looks long. The heart looks elongated. Okay, elongated heart. Okay, we will talk about it. Okay, don't deviate the subject towards really, bigger questions. Coronary artery obstruction. If there is a coronary artery obstruction, what happens? There is less blood supply to a part of a cardiac muscle. Only that muscle dies and only that muscle atrophies, but not heart as a whole. Yes or not? If the whole blood supply to the heart is stopped, what do we call that condition? It's called as cardiac arrest. Yes or no? The patient dies. So you are thinking about two different entities. This is where you are misunderstanding the clinical conditions. Okay? Coronary artery obstruction is an obstruction happening to a part of a cardiac muscle. Brown atrophy of the heart is an atrophy of a part of a heart cardiac muscle. It is not obstruction of the blood supply completely to the heart. It is not atrophy of the heart as a whole. Did you get it, Jabalina and Ashlan? Right? So that's the reason you are getting confused. Yes, the whole obstruction to the heart blood flow will actually cause the patient to die. Okay. Yes or no, Dabelina? Yes, brown atrophy of the heart. Yes, is a very good condition. We will not actually. It is not related to this one, cardiac sizes. Okay. Right. And when we say it is not apparent that it will be able to look, so that's the reason you see here. Even if there is atrophy, the normal cardiothoracic ratio, remember, that is a very good question. Normal cardiothoracic ratio, we call it as normal CTR cardiothoracic ratio is 32 to 50%. Okay, 32 to 50% is the normal cardiothoracic ratio. Okay, if it is less than 32 to 32, we call it as real atrophy. Okay, we call it as real small heart, very small heart, the heart that doesn't grow. We will talk about that interesting clinical condition later on in some other uh, class. But yes, there are some heart conditions which will actually, the normal cardiothoracic ratio will be much less than 30. Okay, we will talk about it, but not necessarily now. Okay, let us not deviate from the chapter. Right, now you see here, the evaluation of the cardiac size is just made on a frontal radiograph along full inspiration and on a PA view. Okay, and then we have to look at the space posterior to the heart and anterior to the spine at the level of the diaphragm in lateral images. In lateral position, what we actually do is that we are going to look for a spine sign. And it is that we are going to look for the posterior space of the heart and compared to the anterior spine at the level of the diaphragm. Let me show you how exactly. And will actually happens is that when a heart enlarge, it will overlap or it will silhouette with the shadow of the spine. So there will be obscuration of the shadow of the spine, silhouette sign onto the thoracic spine will eventually say that there is an enlarged cardiac space. Okay, right? Enlarged cardiac muscle. So that one is actually telling me that there is an apparent cardiac enlargement. Silhouette sign is also applied in a lateral projection. Remember, you see here, this is a normal radiograph. In the lateral position, what I'm going to do is that I'm going to measure the distance between, there is a little hypodense area that is present on the posterior side of the heart. So this is the one that is actually expansion, retrocardiac space, we call this one as, okay, retrocardiac space, where there will be expansion of the heart here. So if there is an enlargement of the heart, the shadow will become more bigger and it will completely slowly obscure the shadow of the spine here. So by this, I can understand that the problem is not present down in the spine, but it is present down inside the heart, right? Blurring of the borders of the thoracic vertebrae is caused by the associated structure here. So what is the associated structure here? It's the heart. Did you understand? Here also I'm applying the same Silotis sign itself. Okay, but it is okay if the anterior shadow, okay, if the anterior borders of the thoracic spine are obscured, it is happening because of the problem that is present inside the heart. Okay, or it might be happening because of mediastinal tumors as well, and some other conditions are there, but we will not be dealing about them right now. But just try to understand one thing, that this heart is obscuring the shadow of the spine, and you can particularly differentiate it as heart shadow. So that's the reason I say that one cardiac enlargement is the one that actually silhouettes with the vertebral borders. Got it? Is this clear? So in such kind of situation, in lateral projection, I will call it as a gross cardiac enlargement. Okay, you see here this picture. You see here, I can clearly differentiate this one as the heart shadow, and it is completely overlapping with the spine, right? Anterior borders of the, there is a blurring of the anterior borders of the thoracic spine, which means to say that they is happening because of cardiac silhouette. So silhouette sign is positive, and I can call it as a cardiac enlargement. Did you understand how I am using the silhouette sign here when compared to the normal image here? This one is the cross chamber cardiac enlargement. Did you get it? There is a blurring of the shadow of the anterior borders of the vertebral spine, and heart is overlapping with them. So that is actually, by this I can came to understand that there is the loss, or you can call it as some other way, loss of radiolucency of the retrocardiac space. This black area is gone. Okay, loss of retrocardiac radiolucency also causes, also called as cardiac enlargement. Did you understand? There are two types of interpretations. One, you are comparing to the borders of the anterior anterior borders of the thoracic vertebrae, blurring of that by the heart. Or other, the complete coverage of the retrocardiac space, which is looking black. So loss of retrocardiac radiolucency is called as also cardiac enlargement. So two types of definitions. Is there any confusion for this? Yes, no, guys? Is it clear? Cardiac enlargement in a lateral view. It's an important MCQ, right? Okay. Now, so what are the common conditions that actually cause, recognizing some of the cardiac diseases? I think we will just take a break here. Okay. We will just take a break here, and then we'll come back once again to do each of the 8 of these all the cardiac diseases. Okay, this is because this is the biggest part here, and measurement of the cardiothoracic ratio is a very important question. So remember that. Okay, I will tell in more details of the measurement of the cardiothoracic diameter when we are talking about particular diseases. Okay, there is a formula for that. We will talk about that one. Okay, but right now, just take a break. It is 11:10 here. We will be meeting around at 11:30. Sorry, 11:20. All right. Okay, 11:20 or somewhat 11:25. Okay, almost 15 to 20 minutes of. Jabelina? Okay, I wish Benedict and Debelina, to look into the complete pathophysiology of the atrophy. Okay, Benedict will look what exactly is atrophy and cachexia. Jabelina will actually look what is the pathophysiological mechanism of atrophy of the heart. Since you came up with two big professional words calling it as the brown atrophy of the heart, okay, where we actually misunderstood for it as a gross atrophy of the heart, okay, maybe we will try to understand what exactly from them. All right, you guys here, Jabelina and Benedict? Okay, I will ask them. Don't worry. Right, so everybody here, please respond, guys. If everybody is here, let's continue and complete this chapter off. It's gonna take a long time. Right, okay. So we are going to start with the conditions of the heart, okay? So we are going to learn about one condition after another condition, okay? Please play a little concentration, okay? It might be confusing, but it is not difficult. So first things, we already know about this condition. We learned it before, so it is quite easy for us. The first thing is actually the congestive heart failure and pulmonary edema. So in particular, I'm talking about here alveolar edema, okay, pulmonary alveolar edema and pulmonary interstitial edema that is actually happening in relation to the heart failure. And that heart failure is nothing but your congestive heart failure, CHF, classically called, and the edema that is actually causing here either could be the pulmonary alveolar edema or sometimes it can be pulmonary interstitial edema. So you see here, congestive heart failure is the one of the most common diagnoses that is happening in hospitalized patients over the age of 65. Okay, generally the heart fails. Okay, we call this condition as a colloquial term itself, but it is not actually heart failing, but it is the ejection fraction. Okay, it is the decrease in the cardiac output of the heart. Okay, reduction in the cardiac output, cardiac capacity is called as a congestive heart failure, and it is happening because of the process congestion, and it is common in patients who are hospitalized over the age of 65. Right, okay. Causes of congestive heart failure, we already know them, that one of the condition is called as a coronary artery disease and hypertension. Coronary artery disease is nothing but the arteriosclerosis, okay, deposition of the atheromatoschlerotic plaques, atheromatous sclerotic plaques inside the cardiac arterioles. Okay, the blood supply of the heart is being obstructed by the atheromatous sclerotic plaques is called as a coronary artery disease. We also call this condition as CAD. Okay, coronary artery disease, and the predisposing factor with that one is hypertension. Any kind of a patient with a hypertension are more likely to develop a clinical condition called as coronary artery disease, which eventually progresses down into congestive heart failure. Now we see here, do not misunderstand these clinical conditions. In medicine, we call these three conditions as different entities. We learn coronary artery disease as one separate disease. We will learn congestive heart failure as one separate disease. We will learn as hypertension as separate disease. But no, all of them are radiographic findings for some kind of a particular condition. Okay. So what exactly is the typical radiographic appearance in a congestive heart failure? The one, there will be pulmonary interstitial edema, or there will be pulmonary alveolar edema. I think we know about these radiographic patterns before. Okay, pulmonary interstitial edema and pulmonary alveolar edema. But not every feature of a pattern is present and often overlap between these two patterns. Okay, so it can be either pulmonary interstitial edema, alveolar edema, or a mixture of both. Okay, so what is the reason behind it? It is coronary artery disease and hypertension. So together we are calling it as congestive heart failure. Right. So what exactly are the four major features of pulmonary interstitial edema? The first thing is thickening of the interlobular septa. The second one is peribronchial cuffing. The third is fluid in the fissures. And fourth is pleural effusions. Okay. I think I remember last time, I think it was Sahil or Aman who was asking about, sir, what is a peribronchial cuffing, if I'm correct, right? Somebody was asking what is a peribronchial effect, cuffing. So I will teach you. I will clear that doubt here itself. Okay. So four features of interstitial edema. Remember, thickening of the interlobular septa, thickening of the interlobular septa, peribronchial cuffing, fluid in the fissures, and pleural effusions are the classical findings of pulmonary interstitial edema. Okay. The first one, thickening of the interlobular septa, are called nothing but the Kerley B lines. Okay, remember, if there is increase in the pulmonary venous capillary wedge pressure greater than 15 mm of Hg mercury, okay, if there is increase in the pulmonary venous capillary wedge pressure from the pulmonary artery, which will cause the accumulation of excessive fluid in the periphery arterioles, okay, which are seen at the base of the lung, and we call such current lines as Kerley B lines. Okay, B means to say base here. Okay, the Kerley B, the Kerley lines that are happening at the base, so we call them as Kerley B lines. And the reason because is excessive accumulation of the fluid happening because of the changes in the pulmonary venous capillary wedge pressure greater than 15 mm. Now, they are named after a scientist, Peter James Kerley, okay, Irish neurologist and radiologist. Okay, he's the one who actually discovered them. So they are thickened septae, are the septal lines that are happening at the base of the lungs. Simple, okay? And they are very short, 1 to 2 centimeter long, very thin, has fissural-like density, and horizontal in orientation. They are never perpendicular. Okay, they are always uh, they are horizontal in orientation. It means to say they are perpendicular to the pleural surface. Okay, or you can call it as parallel to the diaphragmatic surface or perpendicular to the pleural surface. Okay, both the same, both means the same, and they usually extend and abut to the pleural surface. Okay, so we see here, look at this radiograph very closely. I can see thin lines. You see here, some as if somebody has scratched on a radiograph. Okay, they are the thin lines that are happening at the base of the lung. So such kind of an appearance is actually happening because of the presence of Kerley B lines, which are very short, very thin, and horizontal lines that are happening perpendicular at a 90-degree angle to the pleural surface, or running parallel, almost parallel to the diaphragmatic surface. So these lines are happening at the base of the lungs. So we call them as the Kerley B lines. And the visibility of the Kerley B lines is a confirmatory diagnosis for a congestive heart failure. Okay, the increase in the cardiac pulmonary wedge pressure will eventually cause accumulation of the fluid in the peripheral pulmonary arterioles or the venules. Okay, so that's why we see such kind of lines here. Okay, so these are called as the Kerley B lines. I think I have already made them very detailed before classes itself, but here again we are looking them Kerley B lines. All right. Okay, now the second condition we are calling is as the peribronchial cuffing. Generally, I have told you before, the bronchuses are not visible. So how I am going to recognize the bronchus? It is just by imagining, and it is just by tracing out the pulmonary arteries or the pulmonary blood vessels. Pulmonary markings are prominently seen, right? So it means to say, yes, the bronchus is also along with that. It is not visible doesn't necessarily mean to say that they don't exist. They exist, but they are not visible for us in the normal views, okay? But when their walls usually get too thin and are not visible to the periphery of the lungs, okay? In the periphery of the lungs, they are not visible and their walls are too thin. But generally, if they become visible, it is called as peribronchial cuffing. Okay, the bronchuses are not visible, but if they start to appearing on the chest radiograph by thickening, it is called as the peribronchial cuffing. Okay, so that thickening is actually happening because of the fluid accumulations that is happening in the interstitial tissue around and in and the wall of the bronchus. So in case of congestive heart failure, particularly, the bronchial wall becomes thicker and there is a ring-like density that can be seen on end. On end means to say that is seen on the radiograph, okay? So a ring-like density appearing along the bronchus suggests that there is accumulation of fluid in the interstitial tissue and in the bronchus's walls. So that condition is actually called as a peribronchial cuffing. No, air bronchogram is different. Air bronchogram, where the bronchus is normal, it is looking radiolucent. There is no thickening of the bronchus, but the area surrounding to it is hyperdense, right? So it is the fluid-filled alveoli, okay, a normal air-filled bronchus being visible along the fluid-filled alveoli is called as an air bronchogram pattern, right? But here there is fluid accumulation inside the bronchus within a normal alveoli. Get it? Did you get it, Hisham? Okay. There, air bronchogram is generally speaking a normal radiolucent air-filled bronchus being made visible through the fluid-filled alveoli. But here, no, it's not. It is different. Okay. So what happens is that the peribronchial cuffings appears as numerous small ring-like shadows that look like donuts. Donuts, I think you know what donuts are. Okay. You see here, when we look close enough, okay, you see here, this one, it is looking like this. And so it means to say the inner walls of the bronchuses are filled up with water. So that's the reason. And you see here, this is much more apparent here. And this is the accompanying pulmonary artery to it. Okay, pulmonary artery. And they become more visible. So this one, such kind of appearance is actually called as the peribronchial cuffing. Yes, so yeah, in black alveoli, okay, in black alveoli itself, we know that wherever there is an alveoli, there is a bronchus associated with it, right? And when fluid fills up, starting the fluid fills up within the bronchus slowly. So right now, this one is actually talking about your progression of the condition. How does an interstitial edema develop? First, the fluid will be given down in the interstitium where there are lymphatic vessels and blood vessels. So the fluid starts accumulating in the interstitium and then eventually flows down to the bronchus. And once the bronchuses are filled, then the alveoli are getting filled. Did you understand? So what is the early finding of a congestive heart failure? It is the interstitial edema, but not alveolar edema. Did you get it? Did you get it? A mild cardiac condition, okay, a mild increase in the cardiac pressure will eventually cause the congestion of the pulmonary vessels and the interstitium. So the earliest sign of a congestive heart failure is pulmonary interstitial edema. But a chronic congestive heart failure will eventually develop down into alveolar edema because first the interstitium fills up with fluid, Then the bronchuses are filled up with fluid. Then once the bronchuses have fluid in them, they will slowly and slowly flow down into the alveoli. So the recovery of the congestive heart failure is exactly opposite compared to the progression of the congestive heart failure. Did you understand it? The fluid inside the lungs have to be removed first. Then the interstitium will eventually get better by itself. So the therapeutic value of this finding is high. Did you get it? We are trying to analyze the progression of the condition. So that is what a peribronchial cuffing is. Okay, a ring-like hyperdense shadows because of the accumulation of the fluid in and around interstitium. See, interstitium is generally not visible. Alveoli are generally not visible. Bronchus are generally not visible unless there is some pathology. You have to understand this very simple logic right now. Okay, and you see here in this patient, there is a very peculiar finding, but it may not be really very apparent. Okay, there is very apparent. There is a thickening of all the interstitium. You see here, and the bronchus technically became so visible, right? So this is actually the first interstitial edematous pattern, and generally they are happening along the hilar spaces, right? So perihilar opacities, patchy opacities, interstitial pneumonic-like pattern that is coming down along the hilum is technically a characteristic feature of pulmonary interstitial edema. That's what we learned in respiratory system as well, right? So the next one is that we also learned about the fluid in the fissures. If there is accumulation of the fluid within the parietal layers and the visceral layers, along and between the lobes, so the fissure, either the major fissure or the minor fissure, oblique fissure or the horizontal fissure, it becomes a thick line. Generally, they are not visible, but they become visible down as thick lines. So that is actually called as the fluid in the fissures as well, because the lymphatics and the blood vessels are present down in the pleural space, right? So that's the same way here. All the edematic fluid will eventually drain down into the lymphatics. So that's the reason we have the fluid in the fissures, right? And they look like a sharpened pencil line. Okay, a sharpened pencil line here. See, I think you can appreciate it here. Minor fissure, major fissure, right? Okay, then fluid in the fissures, and they will become more irregular in contour. Okay, more irregular in contour, so they will be more visible on an X-ray. Generally, they are not visible. In normal radiograph, they are not visible, but only if the fluid fills up, they are start visible. Right here also, you see here a very thick line, right, and a very thick line, which actually suggests that the patient eventually will develop an encysted pleural effusion. So this is also talking about the progression condition of the patient, right? Fluid in the fissure here also, you see here is almost started developing a lot of fluid here, you see here, and they are flowing downwards because that is the dependent part. And starting from here, they will slowly get settled down in the costophrenic recesses. Got it? So that is the reason why if there is a fluid in the pressure, fluid in the fissures, the doctor is going to expect that the patient is also going to develop a pleural effusion. So now you tell me, if there is a development of fluid in the fissure, will this patient will have mild grade dyspnea or high grade dyspnea? See, there is peribronchial cupping. First thing, there are interstitial changes, interstitial congestive changes are there, right? The second one I came to find out peribronchial cuffing, and the third one I came to find out in the fluid in the fissures. Will he have mild grade dyspnea or moderate grade dyspnea, severe dyspnea? Which one? Yes, moderate grade dyspnea, because you see here, moderate grade dyspnea can be suggested down as difficulty on effortful inspiration. Okay, more he wants to take inspiration, generally the pain will get increased upon more inspiration. Okay, so that is the time when the fluid starts circulating down along the lymphatics. So that's the reason the person will have dyspnea. All right. Okay. Pleural effusion. Yes, pleural effusion will start getting bigger and bigger only if the pulmonary wedge pressure has increased beyond a range of 20 mm of mercury. Okay. If it is pleural effusions will become apparent only if they are greater than 250 ml, and they will be starting accumulating at such massive levels. Okay, at something around like if their wedge pressure is greater than 20 mm of Hg. For peribronchial cuffings and for the Kerley B lines, it should be 15 mm. But for a pleural effusion to start accumulating slowly and slowly, it should be greater than 20 mm of Hg. So remember this one here also. Okay. So pleural effusions are always accompanying heart failures and generally are bilateral. Okay, unilateral pleural effusions, we saw it as acute pancreatitis and malignancies and tuberculosis as unilaterals, right? Okay, and but and congestive heart failure, whenever it is causing a pleural effusion, it is generally bilateral. But always remember, if it is unilateral, it is almost happening because of the right-sided heart failure. Now, let me ask you a condition if you know about this. What exactly is this heart failure? Why does this heart fail? Is it got something related to the ejection fraction, cardiac outputs, and also hypertension? Yes, that's what I came to tell you before, right? It has got a relation to the your blood pressure. It has got a relation to the functionality of the heart. But what is the problem? What is the reason behind the right-sided heart failure? What happens in right side heart? Why the right side heart fails? Is it something that the heart failing on the right side by the cardiac problems itself, or is it something else? Right pumps to the blood, but right ventricles pumps to the blood. Problem in the lungs? No. See, if you are understanding this simple physiological mechanism, I think exactly Reshma is talking here. Okay. See, the pooling of blood has to happen. Okay, the pooling of the blood has to happen. Okay, let me show you exactly so that we can understand this condition. Okay, this is a little complicated, but not so complicated though. Just give me a minute. Yes, pooling can happen, but if it is happening down within, see here, guys, if there is a pooling of blood on the right side, does the pooling of blood also happen in the right lungs? Yes, no. Does the pooling of the blood also happen in the right side? Yes, no. Hmm. Okay, I will share a new one. Okay, can everybody see my desktop? Can everybody see my desktop? Yes? Okay. Now look carefully here. Okay, we have got a heart here. Okay. All right. Now you see here one thing. Let us try to understand. Let us try to understand. Okay, please don't type anything until I ask you because I'm sharing the desktop. Okay. You see here, The blood from the right ventricle goes down into the pulmonary arteries. Okay, but how does the how does the blood enter down into the right heart? It is through the right atrium. Okay, right atrium receives the blood from the superior vena cava and the inferior vena cava, which opens down into the right atrium. Yes, and the right atrium flows the blood from the into the right ventricle through tricuspid wall, right? And then eventually it flows the blood from the right ventricle into the pulmonary artery through the pulmonic wall. So if there is a failure of the heart along this place, what is the dependent area on the right ventricle? Where does the pooling has to happen? Where does the pooling happen? Is it happening on the dependent area? What is the dependent area? Ah, come on, Reshma. Think and tell me if there is a problem that is present here. Okay? Consider, see, there is a problem here. This one is normal. This one is normal. Pulmonary valve is normal and tricuspid valves are normal. Where does the blood start to accumulate? Dependent in the sense, okay, what is the structure? What is the structure? How come it will start pooling in the pulmonary capillaries, man? It will start accumulating in the passive blood flow. It will be back into the right atrium. It will be back into the vena cavas. Did you get it? So that's the reason in a patient with the right-sided cardiac failure, we will be having and measuring the jugular venous pressure. Yes or no? If you started learning this in diagnostic class, I think you will answer about this. Jugular venous pressure, we are the one that will start pulling up of the blood in the dependent areas where it is receiving the blood from. But think about exactly the opposite side here. The left atrium receives the blood from the pulmonary trunk. Left atrium throws the blood inside the left ventricle if there is a problem within, if through the mitral valve. And let us say if there is a problem within the, okay, if there is a problem within the left ventricle, where does the influence happen? The blood flow will be reversed, right? The blood flow will be reversed, and now the lungs got accumulating fluid down inside the lungs. Now, inside the lungs, the fluid pressure has increased, which means to say the amount of blood entering inside the lungs cannot be compensated by the amount of the blood leaving the lungs. Yes or no? So which is the dependent part here? Now this one becomes bigger. The pulmonary artery becomes bigger. Yes or no? Yes or no? Did you understand this complex relation? Did you understand? See, there is a problem inside the left ventricle. Okay, so what happens? Apparently, the left atrium is influenced, and there will be starting up of pooling of blood a lot here in the inside the lungs. And the blood flow that is coming down from the pulmonary trunk, a pulmonary artery, inside the lungs is much more higher than, sorry, is much more lower than the one that is entering down into the blood and entering down into the left ventricle. So this process is eventually called as congestion. Increase in the venous pressure is called as venous congestion. Increase in the arterial pressure is called as arterial congestion. Yes or no? Did you know about these two differences? I think in the chapter in pathology, you will learn about this venous congestion and arterial congestion. Yes or no? It happens in the end arterioles at the levels of anastomosis. Yes or no? So it will always start accumulating fluid down and expanding those blood vessels along the dependent areas. Did you get it? So right-sided heart failure, the dependent area is right atrium and superior vena cava, inferior vena cava. So what eventually is dependent on the inferior vena cava and superior vena cava? What are the structures? What are the structures that are dependent on the right side of the heart? Liver, etc., portal vein, the bigger portal vein, superior mesenteric vein. So a condition called as portal venous tension, portal venous hypertension will eventually be also present. Or if a patient will have portal venous hypertension, the patient will also have the right-sided influence of the heart. So that one is also showing up the influence on the heart functionality. But is there any influence on the dyspnea here? Is there any influence on the lungs? No. See, is this understand? Did you understand? If you are relating it to the physiology, it became more clearer. To present the influence of the lungs, there should be a problem that is present down in the pulmonic wall. Okay, the problem should be present down in the pulmonic wall. Did you get it? A condition like pulmonary stenosis, a condition like pulmonary regurgitation, those are the ones that actually has an influence, because it is all about the blood flowing about outside from the heart to the lungs, right? So you see here, the pooling of the blood has to happen on the dependent areas. So left ventricle's dependent areas is left atrium. Left atrium is dependent on the pulmonary trunk, pulmonary venules, and that one is directly here in the lungs itself. Now, that's the reason we will be seeing a congestion. So such kind of congestion is actually called as pulmonary edema. That is what is called as pulmonary interstitial edema. Did you get it? So this kind of diagonal relationship of the heart and dependency of the lungs is always important for us to know about the cardiac radiographs. Did you understand now? Is this clear, guys? I guess you should have already known about this, blood circulation thing. Unless you are going to understand this, yes, this chapter will be a little difficult for you guys. Okay, so let's continue here. Then pleural effusions, we will not talk about this more yet. We already done it. Okay, right? Okay. Now pleural effusions are there. Okay, and yes, you should also think if there is pleural effusion, we should be thinking about metastasis, tuberculosis, and pulmonary thromboembolic diseases, which are quite common. Then pulmonary alveolar edema. This is what I was talking about. If there is a true pulmonary alveolar edema, it is mostly happening because of the left-sided heart failures. Okay, left-sided heart failure. Okay, and now you see here, before when we were talking, now let's try to understand and relate it to the beating of the heart and see why interstitial edema happened. Okay, let us imagine a situation that the right side of the heart has been failed. And we will think why it is actually causing out the pulmonary edema. Okay, but interstitial edema. Now you see here, the right side could not supply enough blood, and the heart, the left side of the heart is getting normally, it is functioning normally, only this one is not able to function properly. Now what happens? Which pressure is higher? The blood going outside of the heart is higher, or the blood coming the blood going into the lungs is higher? Which one is higher? Going out of the ventricle is higher, or the one that is going inside the lungs is higher? Which one is higher? See, when you are talking about going in or going out, tell me what is the end organ too. The right side of the heart is not functioning well. The left side of the heart is functioning well. The blood coming down from the lungs is obviously being pumped normally back into the ascending aorta. So what is the condition? Going out of the ventricle is high. No, it is not high. It is reduced. It is reduced. Yes or no? The blood going out from this ventricle is reduced. Yes, less volume. So which one are dependent on this? Veins. So before in interstitial edema, when we are talking about the Kerley lines, we came to know it is the pulmonary capillary wedge pressure increasing greater than 15 mm of Hg. And the right side of the heart is always receiving the blood from all these areas, coastal arteries, everybody is coming down and draining down in the right atrium itself. Yes or no? So that's the reason there is pulling up of blood here, and the direct dependent areas are immediately are the intercostal artery, sorry, intercostal veins. So that's the reason Kerley lines start appearing first. Did you understand now? Yes, guys? Clear? Yes or no? I think it takes a little time for you guys to grasp this thing because you are confusing about the which side the blood is flowing and which are the dependent areas. You should be learning about this physiology. Okay, it is difficult, I know, but it is confusing. It is not difficult. It is just confusing. Right. Okay, let me repeat once again. This one is the right side of the heart is not pumping enough blood, but the blood coming down here and entering from the lungs is increased. So what happens slowly and slowly, this blood will, the volume entering down into the lungs is reduced, but still what happens? The heart is beating. The heart is beating. So eventually there is an increase in the pulmonary venous pressure, and also the venous pressure is pulling up and it is also restricting it. So there is dyspnea in that patient as well, right? So somewhere or the other, whatever the blood that has been accumulated here has to eventually enter, because the heart is beating like this. The tricuspid valve closes first other than the mitral valve, right? Slowly and slowly what happens is that more and more, so more pressure is building up. So that's the reason why we start to develop interstitial edema as well. First Kerley lines and then interstitial edema, but the left side of heart is trying to compensate as best as they can. So what will they do? The left side of the heart starts compensating and increases in size by increasing the size of the left ventricle. Did you get it? Hypertrophies. Now you see it. Now what are the accumulating factors here? First, Kerley lines. Cardiomegaly. What is a condition that causes cross cardiomegaly? We learned before, congestive heart failure. Why does it have congestive heart failure, have cardiomegaly? Because of the compensation mechanism. The heart have to compensate the blood that is pooling up inside the lungs because of the increased capillary wedge pressure, along with the blood that is going outside of the heart. So dyspnea is coming, venous pressure has to be compensated. So what happens? The heart beats faster and the heart beats with more energy by compensating as hypertrophy. Did you get it? So, is hypertrophy happening in this condition a good thing or a bad thing? Good to a certain level. So, what are the drugs we are going to do? We are going to give beta blockers, which are going to increase the cardiac output. Get it? So, what is the drug of choice? What is the drug of choice for congestive heart failures? It's beta blockers, right? So I think you will learn them in pharmacology, but let's get into radiology first, okay? So let's complete of this session. Alveolar edema, we already did it. So it will have a classical appearance as bat wings or angel wings or butterfly configuration. We already have seen this condition so much before. Okay, so it will appear down as the central configuration, centrifugal configuration, which the patchy, fluffy, indistinct opacities are actually centrally located along the hilum. So this blood will be seen down as a butterfly. The complete edema will be seen down as the butterfly wings. So that's the reason we call it as a bat wings pattern. Curly B lines. Okay, curly B lines. Left cross cardiomegaly, particularly to the left side, and then increased pulmonary wedge pressure along with an pulmonary alveolar edema and the interstitial edema are the characteristic features of congestive heart failure. Do not forget this. Okay, a fluffy, indistinct white patches that are distributed from center to the periphery. So this one is the end stage. When the patient actually develops such kind of a pattern, there will be severe dyspnea. And that is the reason we are trying to reduce the edema in these patients by giving out drugs like potassium sparing diuretics. Spironolactone, furosemide are the ones that are we giving here. And at the same point of time, we are going to control it with the hydrochlorothiazide, because this is the same time where the RAS system is also being activated. And also you see here, what are the dependent areas of this condition? Dependent areas on these conditions are eventually brain. Dependent areas are eventually liver. Dependent areas are that is related to hypertension is obese. We will not be going down into the pathophysiology of that one right now, but try to understand it has got something to do with your lipid metabolism as well. Okay, right. And it is called as the essential hypertension with no identifiable cause. If there is hypertension with no identifiable cause, for example, to say a patient coming down with hypertension, okay, something like 140, 150 upon 90, okay, if it is coming with no apparent cause, we call it as essential hypertension. But if there is a cardiac component involved, or if there is some kind of a condition like a thyroid disorder involved, if there is obesity involved, or if there is a renal system that is involved, we call such kind of hypertension as secondary hypertension. So all of the conditions that are related to the heart, which actually causes hypertension, are heart failures, coronary artery diseases, cardiac arrhythmias are the common complications of hypertension. Okay, both work hand in hand. Okay, if there is heart failure, there will be hypertension. If there is hypertension, there could be heart failure. Okay, both of them are interrelated. Okay, one will compensate the other, or one will worsen the other situation. Okay, you will learn them. You have to always learn them together. You cannot learn hypertension as hypertension and heart failure as heart failure. When you are trying to learn pharmacology, okay, learn it also that way itself. Do not learn the drugs used individually for hypertension, and do not learn the drugs individually used for heart failure. Turn to learn the drugs that are used in combination with hypertension and heart failure. That is how the best clinical way is. All right. Okay. Now, what happens if there is an increased cardiac tension? Hypertension, what happens is that the heart size is generally normal or sometimes slightly increased in the early stages of the disease until the heart muscle begins to decompensate the increase in the demands of the blood. Okay, but what is the direct organ that is related down to the pumping out of the blood? What is the organ that is directly related to the pumping down of the blood? Which one? Let us say if there is a patient, left ventricle, okay, what is the structure that is completely dependent on the left ventricle? Aorta. Yes, see here, the problem is not about the ventricle. It is the problem about the aorta, right? See, understand the difference here. What is hypertension? Is it vasoconstriction or vasodilatation? Is it vasoconstriction or both? Interesting answer. Okay, which component is higher? Is it constriction or dilatation? Rishma says constriction. Nitish Rai, why do you say it as dilatation? Why does Nitish and Shafiq say it as vasodilatation? Is increase in the blood pressure called as vasodilatation? Or hypertension is happening because there is vasoconstriction? Yes, the answer is both. That is correct. But there is an influence of one component other than the next one. Vasoconstriction component has got greater influence. Increase in pressure causes vasodilatation. Is that so? That is how you are understanding it? See, first there will be vasoconstriction. There will be restriction of the blood flow. And high volume of blood is happening because of the end diastolic pressure. Yes, exactly. So constriction is first. End diastolic pressure is high, so constriction is first. Then what happens is that because the volume of the blood is higher, so there will be compensatory vasodilatation. Yes, it is a component of both. That is correct. But the first thing what happens is constriction. Yes, transient vasoconstriction first and then vasodilatation. Yes, you guys know about it. Now, apply the same thing onto here. So since the aorta is the one that is dependent here, so what happens? There will be expansion of the aorta. And the dependent areas of the aorta are much more expanded, and the dependent area of the aorta that is expanding is your aortic knuckle. Did you get it? The aortic knob and the descending part, here itself, see the ascending aorta and the aortic knuckle are the ones that are being influenced by this, right? Did you understand it? So what is the first thing that can also be seen in hypertension? And also the second thing that you need to understand here is that the heart is compensating, right? How is it compensating the demands? It is compensating the demands by increasing the size of the heart. And the size of the heart, particularly, it is talking about always increasing the cardiac demands. We are talking about the left side of the heart, particularly. Especially, it is the duty of the left side of the heart to pump up maximum amount of blood. So what happens? There will be increase in the size of the left ventricle, and the maximum expansion of this left ventricle will be along the ventricles, and along the ventricles it will be along the septum and the external layers. Okay, so you can see here on a CT scan, it will be the space that is presented down within the ventricle is reduced because one is pressuring up more, right? This muscularity that has been increased up now starts to push the blood with more force, and as a compensation the patient will also eventually develop tachycardia. So the amount of the volume entering inside the heart and the volume of the heart that is leaving outside the heart is compensated. It becomes equilibrium, right? So cardiac output is just nothing but the equilibriums, right? Attaining the equilibrium states, right? So as a compensation mechanism, what happens? This left ventricular size increasing along the interventricular septums, and along the cardiac walls, anterior cardiac walls, is generally a cardiac sign, is a radiographic sign that is seen in on a CT in a hypertensive patient. Did you get it? Okay. But what is the problem here? The lumen means to say the ventricular space, the ventricular chamberal space is reduced. But that's okay. The heart has already learned how to compensate it. The heart has already learned how to overcome the problem that has already been posed, right? So, did you understand what am I looking at? Now, this cannot be a pericardial effusion. Why? Because you see here, there is no difference in the densities between the external cardiac space and the ventricular space. So, since there is no pericardial effusion, the visceral layers and the parietal layers are together. So, I cannot misconfuse by increasing this cardiac diameter as the chamber enlargement as the pericardial effusion, because there is no attenuation of the fluid density here. Did you understand how am I differentiating it now? Yes. So this is not, the increase in the cardiac chamber diameter is not pleural effusion, because there is no attenuation of the fluid density here. It is the lumen also that has been reduced, which suggests me that there is an interventricular septal hypertrophy along with the chamberal hypertrophy as well. So this one is left ventricular hypertrophy on a whole. Did you get it? Did you get it? Did you understand this? Yes? No? Please respond, guys. Right? Okay. Now, we will be talking about one complicated disease. I think if you have understood about the diagonal mechanism of the heart, now this disease will be very, very easier, but a little confusing, but it is easier. Let me show you how. Okay, mitral stenosis is the disease we are talking about. Mitral stenosis is a condition where there will be stenosis of the mitral wall. It happens in a condition called as rheumatic heart disease. Actually made down use for the, what are the dependent areas, or what are the clinical scenarios in a clinical scenario with rheumatic heart disease, which are the valves that are influenced. What is the main reason for rheumatic heart disease? Did you learn about rheumatic heart disease pathophysiology? Did you learn about this term before? Rheumatic heart disease. What is rheumatic heart disease? Okay, what is rheumatic heart disease? Endocarditis. That's an interesting answer. I think, Shubham, you are talking about a separate entity. Valvular pathology. No, you see here, Shafiq gave about the correct answer. It is an endocarditis. It is the endocardial membrane that is being involved. It is the cartilaginous thing. It is the musculature that is involved, which eventually is causing its influence on the valves. But the other condition the other people were talking about, endocarditis, is not, it is something entirely different. We are talking about rheumatic heart fever there. Rheumatic heart fever is entirely different from rheumatic heart disease. Okay? Rheumatic heart fever, yes, they are interrelated, but they will be seen down as two different entities, rheumatic heart fever and rheumatic heart disease. One of the risk factors for development of rheumatic heart disease is rheumatic heart fever. So the main reason behind is those thread-like structures. Which thread-like structures, miss? Which thread-like structures are you talking about? Vegetations. Okay, we will talk about that. That is where I'm coming, finally coming. I'm coming down to the vegetations, okay? I'm finally coming down there. Okay, don't worry about that. So remember, one thing is that the bacterial endocarditis increase in the levels of anti-streptolysin enzymes that is released by the streptococcus bacteria is the one that is actually causing these vegetations on the valves. Okay, it is a granulomatous fibrous reaction because of the increased vegetations along the walls, and now that walls become calcified and they cannot completely close or completely open. That is what is happening in a rheumatic heart disease condition patient. Okay, so as a result, what happens, the heart will fail. Okay, and particularly if it is happening inside the left side of the heart. Okay, if it is happening in the left side of the heart, we call it as mitral stenosis, which will eventually lead the patient down to left heart failure. Did you understand this? Okay, the left side of the heart has got mitral valve, and here we are learning the symptom left heart failure. Left heart failure is a disease as far as we are thinking now, but right now it became a symptom of the left heart failure. It means to say, if there is left heart failure, there will be pulmonary interstitial edema as well, right? Pulmonary alveolar edema as well, and also the conditions that are related to the mitral valve functionality. And what are they? Dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea. All of the things are coming down and placed down into a common clinical condition called as mitral stenosis. So mitral stenosis in radiology becomes a separate clinical condition rather than learning it as a symptom. In other conditions, you will learn it as a symptom, but in radiology, you will be learning it as the main disease because this is where the real problem is. Okay, so what happens? Let me see. In mitral valve disease, what happens is that the valve of the heart generally is narrowed because of the vegetations that are present around the valve. Okay, so the valve is completely narrowed. Now, you tell me, what if the blood, see, if there is narrowing of the blood, the amount of blood entering from the left atrium to the left ventricle increases or decreases? The amount of blood that is entering from the left atrium to the left ventricle decreases. So where there will be eventual pooling of the blood? The eventual pooling of the blood will be there inside the lungs. So that's the reason the patient is complaining of orthopneas. That's the reason the patient is complaining of dyspneas. Did you get it now? So what happens? Will this be persistent or will this be intermittent? It will be slowly progressing depending on the amount of stenosis. Did you get it? It will be consistent, but it will be progressive depending on the amount of stenosis. Get it? Okay. Now, what exactly happens? Now, if let us say that it will eventually cause the increased pulmonary venous hypertension as well, which is happening because of the retrograde pulmonary circulation, because all the dependent areas are there. So that will eventually cause the pulmonary venous hypertension as well, right? More increasing of the pooling of the blood, more capillary wedge pressure, so the blood leaving from the heart is reduced, and the blood entering inside the lung is the same thing. So what happens? The pooling of the blood happens from the artery to the venous, so increased pulmonary venous hypertension, right? So it is because of the retrograde pulmonary circulation, and eventually there is pulmonary arterial hypertension and eventually right-sided heart failure. So first thing, left-sided heart failure, and then the right-sided heart failure. Okay. First thing, left-sided heart failure starts all the conditions and eventually will cause it. Okay. And then what happens is that next the right-sided heart failure will develop. So which means to say we are calling it as gross cardiac failure. Such kind of condition is called as congestive heart failure. So we are not able to differentiate between the right side or the left side. So that's the reason we are calling it as congestive heart failure. We need not differentiate it, but it may be necessary to differentiate it on a radiograph Because we can see here two radiographic signs. What it is there is a first thing, there is the lower lobe cephalization, prominence of the left lower lobe. Okay, so what happens is that there is the silhouette of the left cardiac lung space by the heart shadow, increase in the heart shadow in the left cardiac space. And as a result, since the pulmonary venous wedge pressure has been increased, what happens is that the pulmonary blood vessels inside the left lobe, upper lobes, are prominent. They become more wider because they started filling up of the blood, right? Okay, because the direct pulmonary artery is direct branch. The first branch of the left pulmonary artery is the upper lobar branches itself, right? And we also came to know that this is running posteriorly, right? Posteriorly to the pulmonary artery, pulmonary bronchus here. So that's the reason we will see a direct influence on this upper lobar veins, okay, right, in upper lobar pulmonary blood vessels. So all of them will eventually show up as prominence. So the first sign that is going to happen is called as cephalization. But you also look very, very carefully here. The right side of the heart size is also increased. And now this cardiac shadow has completely silhouetted and completely replaced the shadow of the lungs here. And you see here the acuity of the cardiophrenic angle. So how can I recognize if there is a right atrial hypertrophy or the left ventricular, any hypertrophies, cardiac chamber enlargement? I am going to look if there is acuity of the, cardiophrenic angles. And you see here, there is a silhouette by a homogeneous hyperdensity of the heart that is overlapping or obscuring the shadow of the lower lung fields. Yes or no? That is how I describe this X-ray. So the first thing all happened is the cephalization of the pulmonary blood vessels. The second thing that is happening down with the right atrial enlargement. Okay. Then the third thing that is actually happening down is the left atrium enlargement. So three conditions. Now you see here, this is a chronic patient. This is a chronic patient. This is a classical thing that what I have showed you. Right now, you try to understand here one thing. There are two clinical conditions here. Okay, if you want me to explain this, I will explain more deeper. You see here, one valve is being stenosed, other valve is being regurgitation. Now, think about the diagonal relationship of these blood flows. Then you will understand why exactly I have this radiographic appearance. Do you want me to help you guys, or you will figure out by yourselves? Did you understand here? First, you see here, one is a mitral stenosis. Other is tricuspid regurgitation. Mitral stenosis means to say it is happening on the left side. Tricuspid regurgitation, it is happening on the right side. This one is regurgitation, which means to say there is pooling up of blood inside the. See, regurgitation means to say reflow of the blood into the right atrium. Yes or no? See, talk in right atrium, Shafiq. Okay, when we are talking about it, you talk it on the direction. Okay, don't just say it atrium. We have so many atrium. We have right atrium, left atrium. Okay, we have the anterior parts and the posterior parts as well. So we are actually causing right atrium here. So regurgitation means to say now there is an increase. Now to compensate this blood flow, what does the right atrium has to do? The right atrium has increased in its size to compensate this regurgitation problem. And the left atrium has also increased in size to compensate this problem. So if there is a reverse flow or a restricted flow, one, the restricted flow is happening, other, there is a reflow that is happening. Regurgitation is reflow. stenosis is restricted flow. Both of them are different. So that's the reason I have got left atrial enlargement, I have got right atrial enlargement, and the cephalization of the pulmonary vessels. Now, will this patient have dyspnea? Obviously, yes. You see here that there is a gross cardiomegaly. And you see here in this patient also, there is some thick lines here. Okay, look closer. There are some thick lines. Maybe the patient have undergone a surgery of valve replacement. Okay, valve replacement surgery. Okay, these are the suture lines. Okay, metallic suture lines of the thoracic rib cage. And there is another peculiar finding I can see here. There is lymphadenopathy, which generally could have happened because of the bacterial endocarditis and valve failures as well. Okay, systemic infections mostly. Okay, systemic infections, and most commonly it is happening nosocomial infections, pneumonia, pulmonary pneumonias will happen in these patients as well. So what is the most common cause for nosocomial pneumonias? So see, nosocomial pneumonias will happen, and that is the reason we are going to find out a lot of clinical conditions and appearances here. Okay, right. Okay, now so that's what the mechanism here. So let's get into pulmonary arterial hypertension. This is a very interesting disease, but it is see, yeah, almost everybody is correct. Okay, let's not get into that points there. Right now, pulmonary arterial hypertension. Remember, pulmonary artery wedge pressure, if it is increased greater than 15 mm of Hg, it is called as pulmonary arterial hypertension. Remember, this is a very important topic. Pulmonary arterial hypertension is a very important topic. It is increase in the pulmonary artery pressure greater than 15 mm of Hg. Kelly B lines, it is increases in the pulmonary wedge pressure greater than 15 mg, right? 15 mm of Hg. Okay. Here it is the pulmonary artery pressure that is greater than 15 mm of Hg. And it may be related down to two conditions. Either it can be idiopathic, which is called as primary pulmonary arterial hypertension, and the second one is secondary due to the another disease which is generally called as emphysema. Now I wanted to ask you a condition. If you know about emphysema, why does emphysema cause pulmonary arterial hypertension? And also you tell me here, mitral stenosis is another cause which causes pulmonary arterial hypertension. I think we have already figured out because of which areas are dependent, right? Right? We already came to figure out about mitral tension. Emphysema. Why does emphysema? What is emphysema? Okay, we will get into that detail. First, let me complete off this simple topics. Okay, what happens in pulmonary arterial hypertension is that if there is increase in the diameter of the pulmonary artery, okay, remember, first thing, increase in the diameter of the pulmonary artery greater than 3 centimeter size. Okay, it is called as pulmonary arterial hypertension. Alveoli of the, okay, I will talk about that one. Okay, just wait. Okay, just wait, let us complete this one first, then I will tell you about the relation of emphysema to this one. Okay, we'll talk about that just slowly. Right, you see here, first, pulmonary arterial hypertension is about, you see here, if there is an increase in the diameter of the artery greater than 3 centimeters. It can also be made, the diagnosis can also be made on a chest radiograph as well. But CT is gold standard, and angiography, CT angiography is the one that actually is the most important. Okay, CT is angiography is the most important gold standard study in finding out the diameters of these uh, condition. Okay, Remember that? Yes, it can be also, the diagnosis can also be made on a radiograph as well. Okay, let me show you that radiograph so that you won't be confused no more. See, the same thing, the definition wise, it is both the same thing, increase in the diameter of the pulmonary artery greater than 3 centimeters. Okay, increase in the diameter of the pulmonary artery that is greater than 3 centimeters on a pulmonary radiograph, on a chest radiograph. How do we see it? Look at this image, what I have shown you in your chat box. Okay, look at that image. In this image, actually, what is there? Can you appreciate the which side, the right side of the pulmonary, right side of the lung margins? There is pulmonary artery. Can you see it? Clear enough? See, there is this pulmonary artery which is appearing as a hyperdensity. And when you measure the diameter, you see here this diameter is eventually increased. And if this diameter is increased, it is called as the pulmonary artery hypertension. Okay, as simple as that. This is a direct evidence on a radiograph. Do not confuse it with the bronchus intermedius or pulmonary. You see here, lobar pneumonia. Lobar pneumonia generally will not look like this. Lobar pneumonia will be spreading down like this. But this one is spreading like this. See here, and it is actually following the contour. It is following the structure of the artery, and you can differentiate it as artery. So that's the reason it is called as the pulmonary arterial hypertension. But generally on a chest radiograph, we cannot differentiate if there is pulmonary venous hypertension or pulmonary arterial hypertension. But in CT angiography, I will be able to differentiate both the arteries and the veins. Which one is artery, which one is vein. So that's the reason CT angiography is much more superior than a chest radiograph. Okay, so better learn the diagnosis of pulmonary arterial hypertension on a CT. So the increase in the diameter of the pulmonary artery greater than 3 centimeter when compared to the artery of the aorta, ascending aorta AA, okay, is called as the pulmonary arterial hypertension. Okay, it can be unilateral, it can be bilateral. Right pulmonary artery can also increase, left pulmonary artery can also increase. Okay, and both of them can increase, and aorta as a whole can increase. Okay, so it is completely individual. It should be measured and it should be observed carefully. Okay, generally it is the left pulmonary artery which will be increased, pruning. Okay, so that is the characteristic feature of pulmonary arterial hypertension. Okay, now in pulmonary arterial hypertension, the next one is cardiomyopathy. Cardiomyopathy is nothing but increase in the sizes of the heart. So it can be happening when there is increased systolic or diastolic volume of the ventricles associated with a decreased ejection fraction. Okay, cardiomyopathy is a condition where there is increased systolic and diastolic volumes of the ventricles associated with a decreased ejection fraction. Okay, right? Either the heart has increased in its size, or either there is a lot of pooling up of blood inside the ventricle which has been dilated. So both of the thing is the same thing. Okay, during systole, okay, increased systole problem and increased diastolic volume, the both things is actually called as, will eventually lead down to ejection fraction. So that kind of condition is called as the cardiomyopathy. Okay, which eventually will let the heart size appear as big. So we call such condition as dilated cardiomyopathy. Okay, so decreased contractility and the ventricular dilatation. Okay, decreased contractility and ventricular dilatation are the hallmarks of the physiological mechanisms here. So it is usually characterized by the enlarged heart and frequently associated with imaging signs of congestive heart failure. Yes, so appearance of a gross cardiomegaly should be there. Increase in the cardiothoracic ratio that is greater than 50% should be there. and that is actually happening because of decreased contractility and ventricular dilatation, right? Now you see here, when I am trying to measure down the heart size, what I actually do is that, okay, I draw a central line like this. I draw and measure the diameter of the atrium from here to the central line, okay? And then I draw another line from this one central line to the left ventricle as well. So now this area is called as A, and this area is called as B, okay? A and B. Now, this one became the whole diameter of the heart, or I can say it some other way. I can call the distance between the right atrium to the right ventricle is called as T. Okay, the area between the right atrium to the right ventricle is called as T. So which is measured, okay, which is measured and compared to the complete thoracic diameter, which is the capital T. So T by capital T, or let us say A plus B, and complete thoracic diameter is C. So A plus B by C, A plus B by C should be less than 50%. That is what your formula of a cardiothoracic ratio is. Okay. A is the distance between the right ventricle to the midline. B is the distance from the midline to the left ventricle. Okay. Then C is the complete thoracic diameter. So A plus B by C should be less than 30%. But eventually, when you look and measure in this image, okay, generally you will be given down the values if in these exams, okay, they say that the A plus B, okay, or the complete T, or you can call it as T by T also, okay, you can call it as T by T, okay, which is cardiac diameter. Capital T is thoracic diameter. Please look into your box. It is there in the practical slides, okay? This one explanation of the cardiothoracic ratio is there in the practical slide. So that's the reason I'm not teaching it here in detail, okay? Should be less than 50%. Okay, see, T is cardiac diameter, and by T, if capital T is thoracic diameter. In exams, generally they will give you these values. A plus B value will be given, by the C value will be given, and they will ask you if the thoracic diameter is, measure it and tell me if there is any cardiomegaly or not. Generally speaking, yes, if it is greater than 52%, until 52 it is considered as normal, but generally now for time's sake you write it at undergraduate level as 50%. Okay, if it is greater than 51% cardiomegaly, yes, you can say it, but generally you will be given much more higher values to write. Okay, 56%, 58% you will be given as such way. The more explanation to the cardiothoracic diameters and the ratios is given in the practical slides, okay, because I want to complete this chapter. So that's the reason I'm not teaching it in detail here. Okay, so dilated cardiomyopathy, you can see here, by just eventual looking itself, I can say that the cardiac size is increased. But generally, can you say it as only right-sided heart and left-sided heart? No, I cannot differentiate it here that way, right? So generally, it is all there. The heart as a whole is enlarged. So it is generally happening because of the primary biventricular enlargement. Okay, biventricular enlargement we call it as, so which will cause as dilated cardiomyopathy. Generally, the patient has a history of alcohol abuse, and alcohol abuse causes pulmonary venous hypertension, or causes hepatocellular carcinoma, or decrease in the liver capacity. Okay, so that's the reason there will the patient eventually the patient has developed portal venous hypertension, and the patient eventually developed congestive heart failure. And as a result of congestive heart failure, the patient's heart size is increased. Okay, if we have to go, what is the relation between alcohol abuse and cardiomyopathy? So this is what it is. Okay, and there is another clinical condition. You tell me, if you see this patient, let us say you got this patient x-ray like this, you came to know that he is about alcoholic cardiomyopathy. What is this another condition that you are going to expect in this patient? What do you expect? There is some other condition that you have to expect in this patient. What is it? Liver damage. No, already liver damage is there, that's fine. Okay, what is this another condition that you have to expect in the, no, I don't know, you tell me if it is related to the heart or not. Well, you see, cirrhosis will be there. Cirrhosis is the reason behind his portal venous hypertension. That's it. Okay, blood pressure is there. That is also fine. Portal venous hypertension is there. Cirrhosis is there. Yes, I have already told you that one. But both pulmonary venous hypertension is there. Congestive heart failure is there. Now this patient will progress down and will come up with another condition. What is that? It is a life-threatening condition. I think you know it, but if I tell you, no, not infarction. See, heart failure already happened. I told you, right? There are two conditions happening of alcohol abuse. It is just portal venous failure, hepatic failure, and congestive heart failure. Yes, it is happening. So what will another be affected? Depending on these two things, on depending those things, there will be happening another condition that is called as hepatic encephalopathy, which has got a direct relation down to the congestive heart failure and portal hypertension. Okay, do not ever ignore this. Okay, you will learn more about this in surgery. Okay, hepatic encephalopathy is the condition that is associated with congestive heart failure and portal venous hypertension. Okay, remember that. Mechanism, I'm not talking about it. Okay, you should be able to learn and get that mechanism as well. In this patient, there will be hepatic encephalopathy too. A very important disease here now, thoracic aneurysm, thoracic aortic aneurysm. Okay, thoracic aortic aneurysm is a very simple diagnosis. There is nothing much to learn here. The only thing is that the aneurysm increases in the diameter of the blood vessel, and it is increasing the diameter of the aorta here. And what is the most common cause? Any aneurysm it is causing is happening because of atherosclerotic plaques. Okay. Now you tell me how many layers are there in the aorta? Any blood vessel. Any blood vessel. Okay. 3 layers. Tell me what are the 3 layers? Names: intima, media, and externa, right? Tunica intima, media, and externa. Okay. Now, let us say if there is a complete rupture of all the membranes. Okay. Remember? Yeah. Intia, media, and adventitia. Yeah, that's also fine. That is also the same name thing too. Okay. Right. So, if there is a complete rupture of all the membranes, what happens? The blood inside this blood vessel will eventually hemorrhage off, right? And if there is eventual, which is actually calling as complete piercing of the blood vessel, right? All the blood vessels are ruptured. Now, any kind of a pathological condition, if you relate it to the atherosclerosis will be generally developing down in the intimal layers, and slow scraping of the intimal layers will eventually weaken the layers of the blood vessel. So there will be the blood that is coming down from the intimal layers to the other layers of the blood vessel will slowly starts increasing the size of the blood vessels. Okay, Let me share it. Wait, okay. Just let me show up. You will try to understand what I'm talking about. Just give me a minute. Just give me a minute. Okay, we will take some like another 15 minutes of time because we have another two simple diseases that have been left out. This is the only one that needs more explanation. The other two diseases are very, very simple. Just bear upon with me, okay? We will complete off the whole chapter. From next week, we are going to start with gastrointestinal system. Okay, just a second, okay? See the whiteboard? Can everybody see it? Can everybody see it? Okay, you see here, we have got layers of the blood vessel. Let us imagine we have got layers of the blood vessel this way as well. Okay, this is the lumen of the blood vessel. Okay, this is the lumen. The blood is flowing like this. Okay, now let us say there is some destruction here. Okay, now what happens? The blood will start accumulating here, right? And slowly what happens is that this one will start expanding this layer, and these two layers are strong, right? These two layers are still strong. So what happens is, since there is a pooling up of blood, what happens? They will increase in the diameter. So this is called as an aneurysm. Okay, the same thing what you learned in pathology itself also reflects in radiology as well. Okay, so destruction of the blood vessel layers will eventually cause, but there is another difference, which is actually say that, let us say that the two layers of the blood vessels are completely destroyed. This one is not there, and the blood will eventually flow into the final layer and will start completely filling up here in the main external adventitial layer itself. Okay, so what happens? The heaviness became, and this one cannot break up. So this one cannot bear up the pressure that has been building up. So what happens? The blood will eventually flow down and tear all the layer of the blood vessel. So this is called as dissection. Did you hear these two terms? Dissection and aneurysm. Did you learn it in your pathology and physiology? Yes, right? It is just about the destruction of the blood vessels, which layers have been involved. So it can be two types. It can be a true aneurysm, okay, or a pseudo aneurysm. Okay, both of them can rupture. Okay, both of them can rupture. Now, let us say if I have taken out a cross section like this anywhere, how will it look like? The cross section will look like something like this. See, this is the normal layer. This is the blood that is flowing, and this is the abnormal blood that is flowing. That is what I look in radiograph as well. Simple, very, very simple. Okay, there is nothing difficult here. So what I do, I give a contrast material inside. This one will become more and more brighter, and this one will become also brighter, but I see a separation line in between. So the separation line that is present in between the artery itself, artery should not have separation line. But if I see a separation line in between the lumen of the artery, I call it as aneurysm. That is what my diagnosis is there. Okay, but if I'm seeing there is expansion, there is a gross expansion of the diameter of the artery obscuring the shadow, is called as the aneurysm as well. Okay, so we will see it on radiograph, both on radiograph and CT. If this is on CT and this is on radiograph, how this, see, the mechanism how it tears is the one that is just a reflection that is happening in the radiograph as well. Okay, so that's the reason I say this is very, very simple appearance. it. Here, atherosclerosis is the most common condition. Okay, hypertension is also there, and they are almost abrupt. And the function is actually, you see here, the symptom is the sudden pain, tearing pain that is coming down, and it is always radiates to the back. Okay, it is a cause of a pain which is expanding when an aneurysm is present in the descending aorta. It causes pain. The tearing causes pain, and most of the times it radiates to the back. Okay, classically radiates to the back as well. But there is another condition which is called as acute pancreatitis, which also radiates to the back. So we cannot generally differentiate between acute pancreatitis and radiograph on the radiograph. So that's the reason people recommend it CT. Okay, so to find if you are suspecting an aneurysm, or if you are suspecting that there is a sudden development of epigastric pain and it is continuous and it is radiating to the back, the differential diagnosis, the first thing you have to think about is acute pancreatitis. The second one, if in old age hypertensive males or females, we are going to think about aortic aneurysms. And also another thing, since there will be a lot of hemorrhage, okay, you will also be looking at the internal hemorrhages, which is actually called as gray Turner sign. Okay, gray Turner sign on the abdomen. Okay, gray Turner's sign. Okay, gray Turner sign is nothing but the accumulation of fluid or accumulation of blood and completely blackening, or sorry, complete bluish discoloration of the abdomen, which is called as a gray Turner sign, which is a characteristic feature and resemblance for internal hemorrhages. Okay, it is seen in pancreatitis as well. Okay, gray Turner sign. It is also, it suggests that there is a retroperitoneal bleeding. Since aneurysm is also one of the biggest causes for sudden death of intraperitoneal bleedings, so that's the reason you should be learning about this clinical condition. How will it look like? You see here, there is expansion, sudden expansion of the diameter of the aorta. So it will be greater than 3 centimeters. And also, if it is happening in the descending aorta, also we call it as aneurysm. Okay, if in ascending aorta is this less than 3.5 centimeters, and if it is descending aorta, the normal is less than 3 centimeters, and aneurysm is persistent enlargement if it is greater than 4 centimeters, and the diameter keeps on increasing over time. The more delay you make with the aneurysm, the more diameter increase will be there. Okay, so that's what it is. Did you understand? Is this clear? So how it does look, how it looks like. You see here, there is a very clear expansion of the aortic shadow. That is simple diagnosis enough. There is nothing else. Okay, the right heart border actually shows. Okay, the right heart border is not projecting, but the right heart border is projecting much more in the right side. So it is a rotated X-ray, that is fine. See, I can see here, this is a rotated X-ray, but I can see there is a lot of obscuration of the thoracic lung fields by the aortic shadow. Heart, you see here, heart seems to be normal here, but this one is being obscured by the shadow of the aorta. So this one is a direct diagnosis. See, it is very simple on X-ray, but on CT, so it is generally the descending aorta that is involved. The descending aorta should normally be parallel and should be disappear with the shadow of the spine. In a normal thing, we cannot differentiate the shadow of the descending aorta from the spine. But here, I can almost see here, you see here, this curvature itself says that I'm looking at a descending aorta. Okay, right? So this is how a big thoracic aneurysm will look like. Okay, do not understand the complete logics also, it is fine here. This is a professional diagnosis, but still remember this X-ray image. Okay, we can have an image like this and ask you to say, okay, what is this appearance? Thoracic aortic aneurysm. That's it, simple. Okay, just for examination purpose, remember these images. Okay, right? This is not a very important at this level. And like what we were talking about before on a CT, you see here, this is the normal lumen and this is the destroyed. Okay, this is the destroyed layer, and now there is eventual expansion, and there is a filling up. Okay, so calcification, you see here, when if I'm looking close enough, okay, if I'm looking close enough along this layer, I'm saying atherosclerotic plaques are nothing but filling up of the calcification. When I look closely here, there is a very thin line, white line over the layers of the iota here, right? So this one is nothing but your atherosclerotic plaque, calcified plaque. So that one is the one that is actually causing this aortic aneurysm. You see here, there is a bigger expansion. Generally, the aorta, descending aorta, should be present as a thin circle here, but now it became a so much big, okay, so much big oval density taking up all the space here. So by that, I came to understand that this is an aortic aneurysm. Okay, so it is a very simple diagnosis. A big thing like this cannot be told as a lung mass. Okay, if Sandra that she is present here, this one cannot be called as a lung mass, because why? I am looking at the mediastinal window and I am looking at the soft tissue structure as the lungs appear blank. If this have been a lung mass, it will not show up like this. It will show up more prominent in the lung window, but mediastinal window is done for mediastinal structures. So that's the reason I am looking at the blood vessel here. And this is not a normal study. This is a contrast study because I can see the shadow blood vessels that are being completely white. So we will talk more about recognition of angiography later on. But how can I recognize first? It has no density, but if a contrast material has been given, yes, the arteries becomes to start appear more white. Okay, this is a contrast study, and this is expansion of the aortic aneurysm. Okay, right? Contrast material mixes up with blood. You see here, this is the contrast material almost mixing up with blood, and you see here it is considerable amount, and I cannot see that there is no contrast material flowing along beyond this place. So I can say that this one is a thrombus, the blood clot that is present here. So this one technically indicates that this not rupture. Okay, there is no rupture of the aneurysm. It is generally intact. But this one are technically as dangerous as possible because they will have a what do you say, they will rupture eventually. Okay, but generally speaking, true aneurysms are safer, but pseudo aneurysms are much more dangerous because they will rupture spontaneously. Okay, remember that one as a clinical point. Pseudo aneurysms rupture spontaneously, true aneurysms are intact. Okay, and dissection, how I'm going to look at the dissection is that the blood entering from one layer to another layer and completely flows and tears out the complete layers of the, okay, layer complete layers of the blood vessels. So like I said, what happens, I told you that it is blood filling up within the lumen, other than the lumen of the layers of the blood vessel, right? So they look something exactly like this. If I make a cross section, how they look like, they will eventually look like that there are, it is made up of two parts. Okay, aneurysm is a gross enlargement. Okay, aneurysm is a gross enlargement, whereas dissection is an enlargement of only one layer. So other layers are intact. You see here, other layers are intact, but here one it has escaped down into the blood vessel. So on a CT, how generally, you see here, MRI is more sensitive in detecting a dissection, but CT is readily available. It is an emergency situation. Dissections are much more bigger emergencies than aneurysm. Okay, so that's the reason we do an CT scan. But on CT scan, how actually they appear is that There is a classification. I think you have already learned it in pathology. It is called as the Stanford classification. Stanford classification is nothing but if the presence of the dissection is present down along the ascending aorta, it is called as Stanford A type, and if it is present down in the descending aorta, it is called as Stanford B type. Okay, aorta Stanford A, descending aorta Stanford B. Now, wherever you see this kind of a separation shadow, see here, I told you that there is one single layer. Can you appreciate this one layer here? See, there is a very thin layer. This is the true one, aorta, and this one is the dissection. Okay, this one is the descending aorta, and you see here, this is dissecting. I can see as a separate line. You see here, I can see that there are separate lines. There is a separate line in between the blood vessel, lumen of the blood vessel. So this one is a Stanford type of A dissection. Okay, did you see it? Is this clear? It's a very simple diagnosis, not so difficult at all. Yes, no, guys, right? Okay, the next one, the same thing. It is very simple. See here, I can see that there is a separation line in between, but you see here, this one is a normal ascending aorta, so it one is not involving ascending aorta, so which means to say this one is Stanford type B. So do not, whenever you are suspecting an aneurysm, do not forget to look at the ascending aortic shadow and the descending aortic shadow, because you have to make a classification. Okay, right? But only radiographic sign is that you will be seeing a thin line, separation line between the intima. Okay, intimal layers. Okay, lumen. Okay, a thin line present between the lumen of the blood vessel itself is considered as the dissection. That's the main diagnosis of a CT. Other than this, there is nothing else. Generally, this question will not be asked in a descriptive part, but this will be asked up as an image, so that you have to remember the image of a CT and also remember the image on an X-ray. Okay, it's a very classical film. They will not even change this picture. They will always ask you these images. Okay, either they will ask you this one, or either they will ask you this one. They won't ask you classification. Classification is completely higher. After only surgery you complete learning them, then only you will be aware of all these conditions. But in radiology, no, not necessary at this level. Just remember the image here. X-ray image. Okay, X-ray image, and see this X-ray image and these images. That's what you have to remember. Okay, see, stand for A type examples. See, that is what it is, right? I can see a bigger calcification here, right? And dissection and expansion of the space of the aorta, right? Stanford type B. And generally this is a 3D reconstructed image, 3D reconstructed image, which is the gold standard today. Okay, aneurysms and dissections are generally not diagnosed on an not diagnosed on ultrasound, or not diagnosed on a conventional radiograph. So cerebral angiography, cardiac angiography, we call it as angiography, or a contrast enhanced CT. Okay, contrast enhanced CT, CECT, contrast enhanced CT is the investigation of choice. Investigation of choice, or gold standard test. Okay, do not forget this. It is a very high yielding point in the examinations. All the examinations, okay, all the competitive examinations will generally ask this question so commonly. Okay, because they expect the undergraduates to learn about this one. Okay, contrast enhanced CT is the gold standard test for aortic dissections and aneurysms. Okay, Stanford type B. You see here, this is you generally do not learn about this. This is the performance of the angiography. Okay, we are looking at the cerebral angiography. This is digital interventional radiology. We are doing it. This is the correction. Okay, there are true lumen things and false lumen things. I will not teach about them. Okay, it is a little complicated. A little complicated. Uh, just give me a last 5 minutes. I'm done. I'm completely done with this chapter. You see here, the last thing we will be learning about is the coronary artery disease. There is no big difference between a coronary artery disease and an atherosclerotic disease in an aorta. Both of them are the same. One is happening in big blood vessels, other is happening in small blood vessels. As simple as that. Okay. See, the thing is that if it is happening, if the sclerosis is happening in the big one, we call it as atherosclerosis. If it is happening in the smaller blood vessels, we call it as, what do we call it as? What do we call that condition? If it is happening, if the sclerosis is happening in smaller blood vessels, what do we call that condition? Arteriosclerosis. The same thing. There is no difference between them. There is no difference between them. It is, one is big blood vessel, other is smaller blood vessel. And the thing is actually happens down is that, okay, both of the studies like MRI and CT are considered as the best studies for detection of a coronary artery disease. And generally, what happens in arteriosclerosis is that there will be luminal obstruction of the artery, and the dependent area or the blood supplied area, due to the blood flow obstruction from that artery, they will not receive enough blood, and finally they will be starting up a necrotic reaction. Okay, and they will die. The eventual death, apoptosis, will be triggered in that organs. And sorry, eventually, since we are talking about the cardiac muscle here, so eventually the heart muscle dies down there, because so such kind of condition is called as a coronary artery disease. And how do I detect it? I detect it is very simple. Okay, I just push the coronary artery with a contrast material and see if there is obstruction or not. Coronary artery contrast materials looks white, obstructions looks black. Very simple. Okay, that's it. Okay, where there is an obstruction, that one will show, okay, that one will show up as black. Okay, this one is a complication of myocardial infarction. It's, people don't ask you about this question, but just see here, there is a attenuation density differences here. So since this is a ventricular aneurysm, not necessary this one. Okay, and now you see here, this one is the coronary artery. This one is the angiogram I have performed, and I am looking it on a CT scan. Okay, I will not define which artery you are looking at, because that one will take a lot of time. There are 6 arteries of the heart, anterior descending, circumflexus, okay, posterior descending. There are so many things. Let us not get into that many details yet. Okay, just one thing. I give contrast material, which will have to appear down as a long tube. But now you see here, at some areas, it is appearing black. Did you appreciate it? You see here, where the lumen, if the complete lumen of this coronary artery is completely fine, there is no filling up of the atherosclerotic plaques. But if the atherosclerotic plaques generally do not take up the contrast material, so they start appearing black in the lumen. So which means to say there is narrowing of this blood vessel. You see here, the contrast material is completely narrow here, white thin streak like thing. So this will tell me that there is narrowing of this blood vessel, so which will eventually give me a diagnosis called as coronary artery disease. And you can appreciate, you see here, there are some white dots here, white dots. This white dots is just generally the calcifications. Calcifications look white. Okay, and atherosclerotic plaques are generally 3 types. Okay, 2 types, you can say: calcified plaques, non-calcified plaques, or mixed type of plaques. Okay, filled up with lipids. Okay, filled up with lipids, filled up with calcifications, or both mixed types. Okay, 3 types are there. Calcifications, they look white. This is a calcified plaque, this is a calcified plaque, this one is a sclerotic plaque. Okay, So I think you know about all these risk factors, right? What is the HDLs, LDLs, mechanism of action, how it causes atherosclerosis or arteriosclerosis. I guess that is the same thing that is happening here. And since it is a lipid, and since lipids have got high fat, fat has got water in them, so that's the reason MRI is the best study of investigation for them. But which one is readily available and instantaneous diagnosis? Yes, CT scan. So both of them has equal, you know, uh, equal weightage in finding out the diagnosis. So gold standard do not, they don't ask you, but generally if they ask you, pick it up as angiography. Okay, pick it up as angiography. MRI is also better. If generally when they ask you in the questions, they won't be giving out you MRI. They will be giving out you contrast CT or non-contrast CT. So you have to pick up contrast enhanced CT. Okay, very simple. They generally will not ask you, about other conditions. Okay, right. Last one, that's it. See, I think you can understand here, right? Black arrows are the calcifications and the white arrows are the blockage by the sclerotic plaques, right? And you see here, this is the angiographic image. Okay, this one is also will be given down as an image, and they will be asking you to recognize the modality. They will not ask you to tell what disease it is. Okay, it's not necessary. You see here, when we are slowly getting it, when slowly and slowly, you see here, at some point of time, you see here, this became so narrow. Look at this point where I'm putting at the finger here. You see here, the mouse, the lumen is became much more narrow and became very thin like density. So that is where their obstruction is. Okay, can everybody guys see it? And you see here, the lumen is quite narrow here. There is no filling up of blood, right? You see here, when you look closely in the animation, that's the place where you see here, this lumen is not completely being filled up, which means to say it became narrow there. So that is how, that is actually descending artery. Okay, we are looking at the left descending artery circumflexus. Okay, so that one left circumflex artery, that is the one which is actually having this atherosclerotic plaques. Okay, this is the one. I think generally you might have heard your uncles or whoever, they said that okay, we have done this angiography, we went down for doing angiography. Yes, if they must have been suffering from arteriosclerosis or coronary artery disease, yes, this is the procedure that what they do, and this is what the doctor is looking at and tell you how much of blockage is there. And for this one, if there is a complete blockage, they will have to completely remove of this artery and such kind, and they will be repaired and they will be replaced by another artery, which is actually called as coronary artery bypass graft, CABG. Heard this name before? Okay, CABG, we call it as CABG, coronary artery bypass graft. Okay, or we will also do another method. Both are done on the radiological thing. It's okay. Coronary artery bypass graft is also in these days done radiologically, but before they used to open up the chest and do. But if they are also doing as cardiac arterial stenting or balloon angioplasty. Okay, balloon angioplasty. Coronary arterial stenting, we call it as coronary arterial stenting, is the radiological technique that what we do today. Okay, coronary angioplasty. Okay, balloon angioplasty. Okay, that's it. So two things: be familiar with these conditions. I mean to say the terms. We can ask, okay, what is a coronary artery bypass graft? Okay, what is the radiological investigating modality that is used for the treatment of atherosclerosis. What do we say? We cannot say it as coronary artery bypass graft. We have to call it as cardiac arterial stenting, angioplasty. Okay. These are interventional radiology techniques. We will not learn about that one. Okay. So I think that's it. So comparatively speaking, this with the respiratory system, this is a very quite simple chapter. It is not difficult. You will be having more of MCQs from these chapters. The only question you will be asking for theoretically is cardiothoracic ratio. All others are important for MCQ purposes and fill in the blanks. Okay, that's it. Okay, so you need not worry about cardiovascular system. Respiratory system is much more important. You will be having MCQs and fill in the blanks from this chapter. Okay, and the other things, I have left out one chapter there. I think the chapter is recognition of the diseases of the chest. That one will also have MCQs in it. So read that chapter. Okay, it has got something around like 130 slides or so. It is not difficult, but there are so many MCQs it. And for now, for time related thing, I am not teaching that chapter yet. Okay, for bronchogenic carcinoma, the questions are there in it, the answers to that questions are there in it. Okay, now the other thing is that I wanted to tell you, most probably, okay, today is Tuesday, right? Today is Tuesday. I think most probably by tomorrow evening or day after tomorrow evening, I will post up the assignment. Okay, I will post up the assignment and you have to complete it before March 3rd. Okay, the questions I will give you, it is more like a test that is based on cardiovascular system, general principles and respiration chapters, anatomy, cardiac anatomy, respiratory pathology, cardiac pathology chapters, and general principles, imaging modalities, all the techniques. Okay, you will have an exam which is an assignment. You will write it. Yes, understand? You have to complete it before mostly May 5th. I will give you the questions. It is more of a theoretical exam. You should be writing down the answers. Okay, and regarding the submission of the today's question papers, submit it off. Whoever the people did not submit it off, you submit it off, right? And if you guys want to have a discussion session on that one, yes, we will have a discussion session of the answers for the people who are interested. If not, we will not do it. Okay, right? So I think most probably I will take up again 2 hours class or so, maybe around on Friday or so. Okay, a very small class. We will start up with gastrointestinal